All right, folks, welcome back. If you're hearing this, you made it through the monster airway lecture. Because of all the legwork we did on the airway section, this should be a um, pretty quick talk. I will revise that statement as we get going, but we covered a lot of ground in airway, and so now this lecture should just be applying a lot of what we learned in the previous lecture. So obviously the respiratory system consists of our upper, lower airway. You can have problems with either one of those areas or both of those areas, and our approach to care is going to be dependent on knowing which one is affected, the normal physiology that we're trying to achieve, and how specific pathophysiologies alter that. So you need to know what problems look like, that's our signs and our symptoms, and how to manage both the symptoms and the underlying disease process. So these are the conditions that we're going to be going over. If you want to make, in your notes, if you want to give each one a page or give each one a note card, this is the list that you want to use. Here's a few more, and I promise this list is not as long or intimidating as it looks. We're going to kind of lump these together, and you guys know more than you think you do. And here's the last of them. All right, so we first need definition of dyspnea because that is going to be everywhere. And all that means, we're going to split our word in half here. Dys means problem with or pain with, and the PNEA is breathing. So dyspnea is painful or difficulty breathing. It's one of the most common calls you go on, and it's one of the places where, especially within the last 5 to 10 years, EMS has come just miles in our ability to care for these patients pre-hospital, and what used to be scoop and screw and hope they don't tap out before you get to the ER are now turning into field stabilizations that are resulting in significantly shorter hospitalizations with lower level of care required at the definitive level. All kinds of things can cause it. Musculoskeletal injuries and trauma, common cold, cardiac conditions. There's certain abdominal conditions that can cause it too. So your differential on if all you know is dyspnea going into a call, you have to have an open mind to anything. This lecture, we're going to be focusing on issues within the respiratory tract itself that cause trouble breathing. But you need to be aware of the patient's other medical conditions and their history, because if they have, if they've got a hernia or they've got, tumors, or they've got chest trauma or recent injury or history of pancreatitis. There's all kinds of things that can cause breathing problems outside of what we're going to cover in this lecture. So keep an open mind and just be aware, above all else, that not being able to breathe is scary. If the thought of drowning, makes you think like that's the worst way you could possibly die, that's how these people feel. Fully conscious, fully alert, not underwater, but essentially suffocating or drowning. It's not a good feeling. So if that scares you, know that that's what your patient's feeling and take steps to make sure you're able to help them the best that you can. So we need to understand the basic anatomy. You've got the upper airway, and from the airway talk, that is everything above the glottic opening. Lower airway is everything below it. I want you to take a look at this picture over here real quick. Normally JBL gives us pretty terrible, useless pictures. But this lady here, I'm inclined to believe, might be a real patient. Her forehead looks a little gray. She's got her eyes closed. She's sort of sagging in her chair. She's definitely overweight. That's not a good look. If this patient says they're having trouble breathing, you need to take them seriously. So know the path of air through your airway, starting from the outside world all the way down to the alveoli in each structure as we go. It is all over your test. Goes in through the nose and the mouth where it's humidified, passes the epiglottis, which opens during inspiration, goes through the vocal cords, the glottic opening, it passes through the larynx. You're into the trachea, you get to the carina, splits into the mainstem bronchi, down to the bronchioles, into the alveolar sac. So you warm and humidify it up top. Everything else is just a conduit and a set of safety valves until you get down. Your bronchioles are lined with muscle and can expand and contract based on your body's needs. And then the alveoli are where the gas exchange actually happens. So the size, thickness, and sort of chemical makeup inside the alveoli are very important, and we're going to get into that as we go. So JBL, in its infinite wisdom, has reminded us the primary function of the lungs is to inhale and exhale, which is silly, but when you're trying to troubleshoot a tricky patient, if you're not sure what's going on, go back to the basics, right? I told you guys that there are 2 rules in emergency medicine. Air goes in and out, blood goes around and around. If you can make those 2 things happen, you buy yourself time to deal with whatever else might be going on. So if you feel overwhelmed, just make sure air in, air out, and then you've bought yourself some time to think. Ventilation is the cycling of air in and out, and we talk about oxygenation is actually delivering that oxygen to the red blood cells and then to the tissue, right? So ventilation and oxygenation are 2 separate concepts. You can get air in and out of parts of your lung that aren't perfused, and you're not going to get oxygenation. You can have well perfused lung, but if you've got collapsed or impassable airways, you're not going to get good ventilation. You need both for them to work. Then you've got to get the air down into and out of the alveoli, not just cycling air through the trachea, mainstem bronchi, and the bronchioles. You've got to ventilate the alveolar space for anything to work. Right. On to respiration. That's the gas exchange at a cellular level. You've got a zoomed out view of the alveoli here. I'm not going to call it a macroscopic view because you're not able to see this functional unit with the naked eye, but you can see the tube here, this little white bit is a bronchiole. You've got some smooth muscle wrapped around it that can expand and contract to give you more or less flow depending on your body's physiologic need. That can also cause significant respiratory problems. We talk about bronchitis, talk about asthma. That's a regulatory issue with the smooth muscle around your bronchioles. And you can see these capillary beds that are looped around the alveolar sacs. So you get fresh air from the outside coming in. You get all your oxygen in here, deoxygenated blood coming from the right side of your heart, comes into your capillary beds, picks up the oxygen, dumps the CO2, and then you get oxygen-rich blood leaving to go to the left heart, and then that blood is pumped out into systemic circulation. And at the tissue level, right, so these cells over here, all these guys, are your generic tissue cells, can be any organ, anywhere. But you get this oxygen-rich blood coming in through the arterioles into the capillary bed, and they've got to get really close. The further away cells are from each other, the harder it is for gas to diffuse, and we're going to dig into that when we talk about pulmonary edema here in just a little bit. So you want to get the blood cells close as you can to the cells that need the oxygen. Give that oxygen a nice short distance to hop off. Your body has been producing CO2 as a waste product. Look back at our airway lecture, that gets bound up by the bicarbonate buffer system where it stays in its dissolved state until the red blood cells nearby CO2 pops back out of the solution, binds to the red blood cell, and makes its way back to the lungs. So breathing in, it's an involuntary control, starts in the brainstem. We talked about the medulla oblongata and the pons, your dorsal and ventral respiratory group. Not going to go back over that. You can pop back to the airway lecture to review that. Our diaphragm is the primary inspiratory muscle. There are accessory muscles, and we talked about that in the airway lecture, but you do need to know, it seems piddly to remind you of this, but the diaphragm is the dividing line between the thorax and the abdomen. It pulls down during inspiration, pulls a negative pressure into the chest so that air rushes into the lungs because the exterior pressure is greater than the interior pressure. Passive process is expiration, right? As your chest expands, there's going to be mechanical stretch receptors that are sensitive to expansion, that are sensitive to pressure, and it activates the Herring-Brewer reflex, which I know this was an airway, but I'm going to say it again because it's on your test and National Registry likes to ask you about it. So you get those physical receptors that get stretched and pushed on that say, hey, that's enough. Then it triggers a reflex loop to stop sending the contraction signal to the diaphragm. Everything relaxes and you breathe out. All right. So I've sort of reorganized our slides a little bit. So my lecture might look a little different than JBL's if you download their slides. But I want to talk about general approach to assessing a respiratory patient, and then we're going to get into the specifics of each disease and then the treatment for each disease kind of as we go, rather than doing all the diseases, all of the treatments, and then the assessment. I cannot overstate how important it is for you to stay calm. Trouble breathing calls are scary, the real ones. That moment of recognition where you realize that you've got somebody else's life in your hands will hit you most, I think, on these trouble breathing calls, because they're the calls where the patient feels their own life is at the most risk and you are able to provide everything that they need can be provided by a competent EMS provider, whether it's assisted ventilations, the pharmacology for fixing the most common respiratory issues we run into are all within EMS's scope, and the vast majority of those are in the scope of the advanced EMT. So these can be very weighty, very heavy calls, but you do have an opportunity to make a difference. This is one of the few instances where you can actually save a life within the time course that you have with the patient, but you've got to stay calm. If you get off task, if you get distracted, if you start fumbling, things will go off the rails. Worst call I ever had was pretty early in my career as a paramedic, and I let a respiratory call get away from me, and somebody who was awake and talking and told me their name died on my watch, and we couldn't get them back. In retrospect, I'm pretty sure it was a catastrophic pulmonary embolism. There probably wasn't anything I could have done about it, but knowing what I know now and looking back on what I did, I would definitely do it differently to give him a better shot. So all of that is to say you've got to stay calm on these calls, because your patient is going to be escalated, their family is going to be escalated, and you're going to want to move quickly. But remember, slow is smooth and smooth is fast. Doing something once the right way slowly is better than doing it the wrong way 4 times quickly. So your primary assessment, and Mr. Camp's going to go over all this with you, and sort of beat your assessment skills into your head. So I'm not going to get into the nitty-gritty of it with you, as far as what's in each section. But just know that your primary assessment, right? So you've done your scene safe, you've done your BSI, you're looking at your patient, and it's time to do your ABCs. Most of the things that are going to kill your patient in short order, your imminent life threats, are going to be an A, B, or C problem, right? Because that's your air in and out, blood around and around issue. If you find a problem with the A, the B, or the C, do not stop, do not pass go, do not collect $200, go directly to treating that. One of the biggest issues that I see both in lab and out in the field is people feel like they need to get to a certain point on that check sheet before they start doing anything, and that is just not the case, right? If you walk in and you see somebody who's cyanotic, or ashen in color, breathing 40 times a minute, you can say, let's get some oxygen on as soon as you recognize that there's a breathing problem. Start working on those as soon as you see them. Signs of life-threatening breathing problems. Low blood oxygen, kind of like low blood sugar, will cause altered mental status and confusion. Cyanosis is obviously bad. That's where people turn blue, bluish purple from lack of oxygen. Typically starts to happen in like the mid 80% on your SpO2. Some people will be in the 70s and be fine. Some people will be sitting at 85, 86, and their fingers will start to look a little bluish. But if you see it, it's bad, unless the patient's got, a history of something like Raynaud's, which is a vascular spasm disorder where their fingers will sometimes look super pale or bluish purple. That has nothing to do with their oxygen level. But anybody who's got blue lips or is blue around the mouth, has no color at all and their lips look really dark, that is a patient in trouble. Obviously, absent breath sounds is bad because that means there's no air moving. Abnormal breath sounds aren't inherently life-threatening. Some of them can be. We'll talk about that as we go. Audible stridor. When we use the word audible, talking about our respiratory pathologies, that means you can hear it without a stethoscope. If you walk in the room and somebody sounds like, one of those whistling tea kettles every time they go to take a breath in, you've got a problem on your hands. Stridor is typically an inspiratory sound. It's from an upper airway obstruction, right? So something is blocking the airflow above the level of the vocal cords, and it's not the tongue, because the tongue produces snoring. It can be swelling from an anaphylactic reaction. It could be a piece of food. It could be a toy if it's a kid, or a piece of food if it's a kid. The important thing to note is you can't wait until you hear stridor to be worried about an airway obstruction. In other words, don't think because you don't hear stridor that there's not a problem, because in order for there to be stridor, you're looking at 70+% airway occlusion before you start getting that whistling. So by the time you hear it, you're late to the party. That train is left, and now you got to find a way to jump on. Fatigued effort. This one, until you see it, and I have not yet found a great YouTube clip that like really captures what this looks like. But if you walk in, if you ever seen like a little kid who's just exhausted at the end of the day, they've got that 1,000-yard stare, they're not really interacting with you appropriately, all of their movements seem sluggish, they just look weak and tired out. If you see that in a patient having trouble breathing, you need to do something 5 minutes ago. It is a gut feeling. You'll hear me talk about the word Gestalt. It's a German word that means sum of the parts, like SUM of the parts. And it's the gut instinct. We use it in medicine to describe the gut instinct you get from your collective knowledge and experience where you think, I've seen this before, I know this is bad, I don't have any hard evidence other than I've seen this, I know how this movie ends. So if your overwhelming impression when you look at a trouble breathing call is, oh, that person looks like they're going to fall asleep, they are about to take a nap, a big old dirt nap, if you don't get on your horse and do something about it. More that 1 to 2 word dyspnea. So that's the patient who can't say much more than a couple words before they have to catch their breath. These people are usually super agitated. Their respiratory rate is so fast, their respiratory demand is so high that they're unable to speak in complete sentences. That is bad news. Cough, there's various shades of coughing, but people who can't stop coughing, who are changing color because they're coughing, coughing up blood, coughing up pink foamy stuff, all of those things are bad. The person who occasionally coughs, doesn't bring anything up, or brings up a little bit of phlegm but is otherwise fine, that's not life-threatening. But there are life-threatening coughs, and we'll get to those kind of as we go on. Tachycardia in excess of 130 beats per minute. Again, not hard and fast. Some people have AFib and will exceed this on their own. If they're in severe pain or if they're hypotensive for some other reason, you'll see this. But that rate should scare you in a trouble breathing patient, because what that tells me is their body is sensing a lack of oxygen delivery, whether that's from a low blood pressure or from a low oxygen supply, and they are dumping epinephrine into their system to try to boost circulation and boost respiratory drive, and that's what's popping that heart rate, up above, what we would consider sort of normal tachycardia of that 120 to 130 range, where you can kind of write it off as being anxiety driven. So if you've got other of these signs and symptoms with that high heart rate, that person is struggling, they're hurting, they need help. We talked in airway about abdominal breathing, accessory muscle use. I'm not going to belabor that one. Irregular rate or rhythm. So, if they all of a sudden change, right? They go from being fine to breathing 40 times a minute, or they go from breathing 40 a minute to 12 or 15 a minute, and you didn't do anything to cause that, you better be checking a mental status, checking a SAT. Sudden dramatic changes can reflect decompensating condition. Pallor and diaphoresis, that gets back to the tachycardia and the epinephrine, right? When somebody's hanging on by nothing, I call it catecholamines in spite. When their body is dumping epinephrine to stay alive, that causes profound vasoconstriction and sweating. So that's what will make them look pale and be sweaty. That goes hand in hand with the tachycardia. Now, retractions, accessory muscle use, we've talked about that. And tripod positioning, which we're going to see pictures of on the next slide, but that is them having so much trouble breathing that they're trying to reposition their body to make airflow easier. Like, they're so desperate for air that they're going to realign body structures that, on any other day work just fine for getting air down to the lungs. They're trying to squeeze every last little drop of efficiency so they don't have to work as hard to breathe. We've got some tripod position pictures coming up, promise. Obviously, somebody who's unresponsive, minimally responsive with a dyspnea complaint warrants immediate attention. And this is all part of that primary assessment. When you get to that breathing box on your assessment, or that airway and breathing box, this is all stuff that factors in to that. Position of the body, are they tripoding? Are they sitting bolt upright? Can they not lay down? Stable or unstable, I hate this word. It just means, do you have a minute, or do you need to do something now? Right? There's plenty of stable patients like somebody having an MI whose blood pressure is fine, whose heart rate is fine, that needs to go to the hospital. Like you need to have wheels turning as soon as like you put the truck in park, get in, let's go, is what's best for that patient. But you can also have a profoundly unstable respiratory patient where slinging them on the cot, getting them to the ambulance, not doing anything for them in between will cause them more harm than you taking some scene time and stabilizing their respiratory problem before you leave. So really what stable or unstable is should be a check in your head of, do I need to do things now, or can I continue with my assessment and do things later? And I'll leave it at that. That's something you're going to have to flesh out as a provider, what your threshold is for scoop and screw versus hold up, I can fix this. You know, spooky vitals be damned. There's things I can do to make this better, and it's better to do them where I have space and resources versus the back of the box all by yourself. You want to check for responsiveness. AFPU, it's from basic. Looks at the amount of oxygen going to the brain. Remember, there's a ventilation component to that and a perfusion component. You need to have both. Is it hypoxia? Is it hypotension? Is it a little bit of both? What's the driver here? But always consider poor respiratory function as a cause for altered responsiveness or mental status. It can be from low oxygen or high CO2. Can both cause confusion. Patent airway, I don't think there's anything new there for you guys. And we talked extensively in the airway talk about how to assist a patient with the BPM and the factors you need to think about while you're doing it, and how to figure out, is their breathing adequate? A little bit more on that to come. Checking your breath sounds. For me, this is part of the breathing assessment. Some people will lump this into a secondary survey and call it part of looking at the chest. For me, especially on a trouble breathing call, this is part of my B. I'm going to walk in the room, hey sir, my name is Rick, I'm the paramedic. What's your name? What seems to be the problem? As I'm going to check a pulse, I'm feeling his skin. And as soon as he's done talking, I've got that stethoscope in my ears. I'm like, oh, sorry to hear that. Let me take a quick listen to you. Right. So I've already, to me, that's part of the B, and it can be done quickly if you're a smooth operator about it. Just don't be weird about your breath sounds. Don't worry about where to put it. Just get it in quickly, especially on a trouble breathing call. You want to listen to several breaths in and out. Remember, you always want to move from side to side. I don't care which side you start on. All right, let's say you start here. Your next breath needs to be here. You don't want to go down, because what we care more about is the difference between side to side, right? Is the right equal to the left? Picking up on differences side to side will help you tease out pneumothorax, pneumonia, pleural effusion. Right, so you want to go 1, 2, 3, 4. If you can listen to their back, bully for you. If they're 300 pounds sitting in a recliner or laying in bed, it ain't gonna happen. If you want to do it when you transfer them to the cot and their condition allows, that's great. Follow the same principle. I always start on the right, but that's just me. I don't care if you want to start on the left, you can do that. And you can reverse those side to side it doesn't matter, as long as you're sticking to the same level, going right to left before you move to a different rung. So I've got a clip that'll show you what vesicular and bronchial sounds sound like. Vesicular is sort of normal airflow through the alveoli. Bronchial describes normal airflow through the larger tubular structures. You'll sometimes hear it called tubular breathing. That's airflow through your trachea or your main bronchi, your larger bronchial tree. If you guys have a stethoscope, want to try this out, hit pause, pop your stethoscope in, put your stethoscope sort of below the Adam's apple region, sort of right in between your collarbones, and take a listen. That's going to tell you what bronchial breath sounds, those tubular sounds sound like, because you're listening right over the trachea. And if you want to pop your scope sort of out to the lateral margins of your lungs, sort of nipple line out to the sides, that'll give you a good vesicular sound. You can hear that airflow through the alveoli. I've got a clip coming up. And then adventitious just means any abnormal sound. So you can have rails or crackles, rhonchi, stridor, wheezing, or snoring. We'll talk about which ones go with which pathologies as we move through here. All right, so here is the breath sound video for you. All right, hopefully you all found that breath sounds video helpful. It's a lot more helpful if you've got headphones, especially ones that go all the way around your ears on both sides. That'll let you really appreciate what you're hearing. We'll talk about sort of what each sound means when we get to the disease that it's relevant to. This is a really helpful chart. You might want to copy paste it into a separate document. If you've got a printer, go ahead and do that. This will guide I would want this on hand while you read this chapter or watch the rest of this lecture. It'll just help keep things sort of nice and organized. And I think it's a good tool for y'all to study to make sure you understand the pathology, because each sound means something specific and it'll tell you about the disease process that's happening, and that can be a tremendous help from a test taking standpoint. All right, unless you want to assess your circulation, because it's your primary assessment, and you can have respiratory compromise due to poor circulation, either not clearing the CO2 because there's none of it coming back, you are unable to deliver oxygen because your pressure is low, will all present like a respiratory issue, even though it could be a circulatory problem. Transport decisions, part of your primary. This is the really important point here. Address the threat. If that means setting up CPAP, starting a nebulizer, getting an IV, running some fluid before you leave, then that's what you've got to do. I don't want to encourage you to screw around on scene, but the notion of, oh, they're really sick, let's just get in the truck and drive, is antiquated and will kill people. There are things that we can do that will save a life, and you guys getting confident at deploying them quickly and effectively will do a better service to your patient rather than going, he looks bad, let's go. You do want short scene times, but you need to provide only life-saving interventions. Now that can have a broad definition. Like I said, sometimes it's CPAP and some meds. It could be a nebulizer treatment, could be administering epinephrine. You all will have skills now as advanced that are truly life-saving. And here in the state of Tennessee, you'll be on some 911 trucks now where you're going to see patients circling the drain and you guys have got to fish them back. So just note that stabilizing a respiratory problem is life-saving, and scoop and screw can kill just the same as faffing around it. Faffing is one of my all-time favorite words. It's not a dirty word. It just means sort of aimlessly rushing around, or you're screwing around on scene. Obviously, that'll kill somebody, but so will slinging somebody on a cot without stabilizing them if they're not going to make it to the truck, or you're not going to have room in the truck to do what you need to do. You can do your secondary assessment on the way to the hospital. That is okay once you've stabilized them and started transport. If they're stable, and you don't see any need to immediately start treating and then boogie, you can get your whole assessment done on scene and come up with a more comprehensive plan. That's fine. That's where you can progress into that secondary assessment on your check sheet. Just keep in mind, Chris will show you this, transport decision is at the very bottom of primary assessment before secondary assessment. You've got to make the transport decision to figure out where you're going to do the rest of what you have to do. And National Registry is going to be looking for you on your psychomotor exam to give that transport decision before progressing through your call. Getting a good history is a skill like anything else, and it's understanding how to ask questions to get what you want. Open-ended is really important. If you ask somebody, does it hurt here? They're going to say yes if they're in pain, because they just want you to do something about their pain. So instead of saying, does it hurt here, and pointing or touching, say, sir, can you point where it hurts? Instead of saying, are you having trouble breathing? It's, tell me about your breathing. Don't put words in their mouth, because then you're going to be guiding their responses based off your presumptions rather than getting the information from them as a primary source. Um, OPQRST is really good. It's really important. As a good clinician, being able to dig in to really figure out what's happening is important. However, I want you to keep in mind this is all after A, B, C, and stabilization. I only say that because we had a huge problem with the last class in lab where people would be asking OPQRST questions when old Sim Man's sitting there cyanotic with a SAT of 60, heart rate of 140, respiratory rate of like 56. And they're asking, sir, when was the last time, this happened to you? So just keep in mind, this comes after the ABCs. Has this happened? And, what have you done before we got here? Has this happened before? What did you do then are super important. I told you in airway, if you get a respiratory patient who tells you, I've been intubated for this before, you got to get rowdy, and you got to get rowdy fast, whether that's with your treatments or, boogieing to the hospital. You can't screw around if that's their history, or if they tell you, I've used my inhaler 12 times today. I took an extra dose of my steroids last night. I turned my oxygen up on my concentrator and I'm still struggling. That's a very different story than somebody, who's taken themselves off their oxygen and is sitting there smoking a cigarette, who might have a very simple fix to their problem versus the patient who's already tried, thrown the book at it because they've been here before and it's still not working. This is a decent time to assign your partner to grab some vitals while you're taking the history. Respiratory pattern, to me, that's part of your ABC, sort of your primary. You should know their respiratory pattern before you ever make contact because you're checking that out from across the room. You're going to learn some buzzwords, certain affiliations that go with certain disease processes, right? When I hear a kid who said this started when I was playing outside, it's probably asthma. When you hear, somebody who's overweight with big swollen ankles say it woke me up, I can't lay back down, or I've got to, I have to sit up all of a sudden, that's congestive heart failure. I can't stop coughing and my wheezing is getting worse and worse, and somebody who's rail thin, yellow fingernails that are nice and rounded off, clubbing, that's COPD. So you're going to have to learn sort of what goes with what and start looking for those buzzwords. And we'll do that as we get into the test, because it's a good test taking strategy, but it'll suit you well in the real world. Sample is important, right? Even if you get a crappy, history of the present illness, you can't get a good medical history out of the patient. Take a look at their medication list, right? That's going to tell you a lot about what they've got going on. We've got a big pharmacology project coming up that'll force you to kind of engage with common home medications and get you in the mindset of looking at those and figuring out what they're used for. Guys, this is a big one, right? Somebody's having trouble breathing. Keep it simple, stupid. That's not just me being crass. That's a pretty, keep it simple, stupid is a pretty well-known mnemonic, right? If they can't breathe, don't make them talk a ton. Please be minimal, get your treatments going, stick to what you absolutely have to have. Again, all this information will let you in the hospital figure out what the best course is, and it is super important that you get this if they're able to provide it. And if they can't, get a family member, get a bystander, take a look at their hospital record. A lot of patients will hand you discharge papers and they'll give you a problem list and a, visit list. That'll give you a sense of what you're getting into. So your secondary assessment, this is your thoroughhead. This is where you're looking at everything that isn't directly related to the chief complaint, right? You're going to sort of check all of your organ systems. You're going to take a detailed look at each one. Your increased work of breathing, chest trauma, or accessory muscle use, to me, that's part of your primary. I had to add this bit because I take issue with JBL putting this in here as a secondary. If it's pronounced or clinically significant, you need to have seen that before you get to this stage of the game. To me, that's a failed breathing assessment if it takes you until right now to figure out your patient's got increased work of breathing. You have to make a conscientious effort to practice this, right? Do this on yourself. Do this on your friends, on people you live with, on your interfacility patients. If you're on one of those trucks right now, get in the habit of doing that assessment in the background, right? I normally do a trick, where I stand up in front of the class and I, try to pick out who the smokers are in the room, just by having watched you guys sitting there breathing since class started. I can usually figure it out. So make it a skill to learn what normal looks like, or if you live with a smoker or somebody who's got breathing problems, get used to assessing that at a distance, and then get up close and learn what it looks like, when your ambulance box apart from each other. Try to automate that process so it runs subconsciously in the back of your head. This is where you take your full set of vital signs. Now, during that primary survey, I told you you're putting your fingers on the pulse, but that's just to figure out, is it there? Is it weak? Is it strong? Is it fast? Is it slow? I'm not counting anything. I'm not going to sit there and count respiratory rate either. I can ballpark 30, right? And if you're close or over 30, we got a problem. If you're below that, yeah, I've got a little bit of runway left, let's keep going. But this is where you're actually going to want to take your blood pressure, count your pulse, count your respirations. You should have popped your pulse ox on by this point, but if you haven't, now would be a real good time to do that. Respiratory calls, pop that on super early. It's quick, it's easy, it's non-invasive, takes absolutely no time for you or your partner or first responder to take care of that. If you haven't checked for breath sounds, this is where you want to do it. Hopefully you did that as part of your rapid primary. If you work on a truck that has a peak flow meter, good for you. But this would be a time where if you haven't put them on capnography and you're in tidal CO2 monitoring, ask the paramedic you're with, hey, do you want this guy on capno? A lot of them, if they haven't thought of it already, will say, yeah, that's not a bad idea, or sure, it's not going to hurt. Me, I default. Everybody who's got even a whiff of a breathing issue or an altered mental status, I'm popping on that capno. And then you've got to do your reassessment, right? After every treatment, you need to loop back to the top and reassess. And then when you get to the bottom of your assessment, you've done everything you need to do, all your interventions, done a full exam. Don't forget to loop back to those ABCs and make sure that they're where you left them or they're heading in the direction you want them to. And this is, again, you just want to confirm that what you're doing is working. And it's sort of at this point, right, where you've assessed, you've intervened, you've completed your assessment, you've confirmed that your interventions are working, because all of them usually take, a couple minutes to get going at a minimum. This is when you can start taking some notes, make your call to the hospital, whatever the case may be. Guys, write stuff down. I don't care if it's a piece of tape on your leg. You can do the glove thing if you're good about getting a picture of it before you throw it away. But get a notepad. I gave up all of my dignity at some point and got a little pilot's clipboard that I had strapped to my thigh because I worked on a fly car. I was all by myself. I had nobody taking notes for me until the transport unit got there, and that could be 20, 30 minutes out. Get something to write stuff down so you can spot patterns and give a good record to the hospital. here's your buzzwords for adequate versus inadequate. Useful in the real life, but also like these are, right? You get this on a test question, like it's a breathing problem. Like, what are you gonna do about it? Obviously, we're not gonna fix barrel-shaped chest, but that's a warning that that person's got a significant respiratory history. And if it's acutely barrel-shaped, yeah, that's a huge problem. So these are what you want to look for real life and on your test. I'm not going to beat them too hard right now because we're going to assign them to the diseases as we go. General pathophysiology, you got to have both good circulation and gas exchange, both in the lungs and at the target tissue, right? So you got to have air going in and out. You got to have good gas getting into the blood. You've got to have good blood getting to the target organs, and then you have to have good handoff of gases to and from the target organs. And you get a break in any, you knock any one of these out, and you start having tissue oxygenation issues, which is going to be our definition of shock when we get to the shock unit here after we do airway and breathing. So you can have sort of direct impairment, or you can have a control issue, right? So if you've got something physically blocking the gas or a control center problem that's not cycling the gas appropriately, that can be your cause. And we'll use obstruction to mean not just like a foreign body. You know, it could be mucus, it could be phlegm, it could be your bronchioles are clamped down super tight from an asthma attack. So just keep that's not a rigorous definition of obstruction. It doesn't just mean they've got something stuck from the outside world inside where it shouldn't be. All right, this is your cheat sheet. Take this out, print this out, learn it, love it, know it. These are all your conditions and all the sort of the big scary signs and symptoms that go with them. A lot of these, not all of them, but by and large, you know, they try to give you the sort of unique or characteristic findings that go with them. So learn it, know it, love it. The quicker you're able to dial in on the problem and the more precise your early interventions are, the sooner you can fix either oxygenation and or ventilation, you can avoid getting in trouble, right? It's a lot easier to stave off a crisis than to dig your way out of one. So being able to really, really quickly recognize is this upper, lower, and what's driving it will let you rapidly treat it and prevent things from getting out of hand. We hit on this. Airway chemoceptors pick up CO2 by proxy by measuring the pH of the cerebrospinal fluid. We talked about acid-base balance, how increased CO2 tips that whole reaction, drives it over to create more hydrogen ions, drops your pH. That's what the brain senses. That's your hypercarbic drive, right? Hyper high carbic CO2. So you're driven by high CO2. COPDers have chronic retention, where they're always running a little bit high and that system loses some sensitivity. So they switch to hypoxic, right? Hypo, low, oxic, oxygen. So you switch from a high CO2 driver to a low O2 driver. It's in your book, and it's sort of an urban legend at this point that giving oxygen to a COPDer will cause them to stop breathing. Not in the time span that you've got them, and if their sats are low, spoiler alert, they don't have enough oxygen to begin with, so you're not going to kick the hypoxic drive out from under them by restoring them to a normal level by giving them supplemental oxygen. So that's sort of bunk bilge nonsense. Don't withhold oxygen from somebody who's hypoxic or really struggling. You got a couple different things that can cause shortness of breath. And some of these are your conditions that we're going to talk about. Keep in mind, it can also be trauma. Guys, broken ribs hurt. Broken ribs might be the most painful injury, that I saw at the med, that we didn't knock somebody completely out to deal with. Right? Broken ribs cause pain when they breathe in, causes shallow breathings, causes lungs to collapse, alveoli to collapse on each other because they don't get inflated regularly, causes low oxygen state. And you can have sort of the more, mechanical problems, right? You use an opiate that blocks those chemoreceptors in the brain. You don't get that signal transmission saying, hey, you need to breathe. So why do these things cause trouble breathing, right? What is the physical reason that these patients have trouble breathing secondary to those disease states? So atelectasis is, the best way to think about it is just sort of a crumpled lung. So it's all your alveoli start to close in on themselves. They start to stick together, right? Because there's moisture in there. They're very, very small. They live very, very close together. So you start getting alveolar collapse, right? So this is not a pneumothorax. The lung tissue itself is not changing its size to the point where it's shrinking in like it's getting compressed. These are the individual little air sacs are closing themselves off. So there's no, until the patient takes a really deep breath, or you give positive pressure, or you apply some CPAP or some PEEP to pop those back open, they're not getting used for gas exchange. Damaged alveoli, that's going to be your COPDers, where there's been direct cellular trauma that's decreased their function. You also start to see that with like sepsis and ARDS patients, where there's inflammatory reactions happening that are damaging the cells in the lungs. That's what's happening with COVID. That's part of why these patients are getting super hypoxic, is in the late stages, is sort of direct lung trauma. There's a thromboembolic component to it, but there are viruses that cause direct damage to the lung cells themselves, and they lose their function. Blocked air passages can be a foreign body, but can also be mucus, can be, the bronchioles are clamped down really tight. So you've got poor flow because of that. Blood flow is obstructed. They could be hypotensive. They could have a tumor, but sort of the big one that we think about as a pulmonary embolism is preventing blood from cycling through those respiratory structures. Or the space around the lungs is filled with air or fluid and the lungs cannot fully expand. So that's going to be your pneumothorax or your pleural effusions. Guys, that air hunger is that desperate feeling that causes people to become almost combative and frantic during a true respiratory distress call. So dyspnea is just that sense of I'm having trouble breathing, but air hunger is I'm not getting enough air, right? Their brain is aware of the fact that there is not enough air getting into their lungs. That fish out of water feeling, that is petrifying. And if somebody tells you that they can't get enough air, again, you're looking at a very, very sick patient. Chest tightness can be from overly expanded lungs, can be from, wounded lung tissue, could be cardiac in nature, but that feeling of I can't get my chest to expand because of the pain can also cause shortness of breath. So because of that, cardiac conditions cause chest tightness that makes it feel like they can't breathe, even though there's no direct problem with the pulmonary structures or chest wall structures at that time. Keep in mind your trauma patients, especially if they're in a lot of pain, are going to breathe fast. If they've got damage, even superficial damage to their ribs, bruised ribs, or a fractured rib without any other complications, they're going to breathe fast and shallow just because of the pain. So being able to tease out, what's anxiety and what's pain versus what's a real disease state that we need to be dealing with is a bit of an art. It's a bit of a nuance until you've seen it, done it a few times. You're just not going to know. You're always better to overtreat and assume that it's a breathing problem, and then realize later that it was just due to pain or anxiety. But take the patient as a whole. Don't just look at rapid shallow breathing in a vacuum. If they fell and have an open ankle fracture and have no other injury, no reason, no history of a breathing problem, and they're breathing fast and shallow, that's not a respiratory distress patient, even though when you get dispatched to it, dispatch asks that your primary reason for going is going to be the fall and the ankle injury, but it's going to get coded for trouble breathing because your dispatcher has to ask, is the patient breathing completely normally? And if the caller says no, he's breathing really fast, or he's barely breathing because his breaths are shallow, now you're getting dispatched to a Delta level call instead of a Bravo or Charlie level call because there's breathing involvement, even though it's just from pain. So assume it's respiratory till proven otherwise, but just know that pain and anxiety from other systems can cause a false respiratory presentation. All right, into the meat and potatoes of this. Let's talk about the actual diseases you're going to see and what you're going to do about them. You can have infectious processes. Can happen in the upper airway. These can be things like epiglottitis is the big one that you guys will get tested on. That you might see in the field. You can have like a sinus infection that causes trouble breathing, or tonsillitis, or like a pharyngitis, sore throat type deal. But epiglottitis is the one that I'm going to show you a picture of that will be on your exams and really is a imminent life-threatening emergency, or can be. And then lower airway infectious processes, pneumonia. That's going to be the big one. And you get the problem is twofold. You get gross obstruction of the airway, right? You get generalized obstruction from swelling, from phlegm, mucus accumulation. You can have pus. You can have a little abscess that forms within the lung. So you get direct obstruction of airflow, but you can also, the swelling, particularly in lower airway infections, can cause a pulmonary edema-like state, pro-inflammatory state where you've got high immune system activity, swelling, inflammation, cellular destruction, toxins accumulating in the area, and inhibits the respiration, the gas exchange at the cellular level gets impeded by these processes. So over here on the left is epiglottitis. So if you remember from the airway talk, right here is our happy little normal epiglottis, and then over here is big ugly. So this horseshoe-shaped structure here, that's your epiglottis. It is supposed to look like that, but you can see it is swollen to, that wide, pretty much all the way around, and this little straw-looking thing is about all the size breathing tube you're going to be able to get through there. So you can see why that would cause a problem with airflow. Classically, this is taught as being a pediatric disease. However, It's typically caused by the Hib virus, which we now have a vaccine for. Sorry for the interruption. I got a funny look from wifey across the table here. She's a physician. I said a Hib vaccine against the virus. It's a bacterium that causes croup predominantly, or epiglottitis predominantly in kids. So there's now a vaccine against the Hib bacterium that's given to young children. So we've seen a significant drop off in epiglottitis in the younger population. So even in this course, it's going to get taught to you in peds, but do not write this off in adults. So in kids, we talk about them having a muffled, muffled voice, excessive drooling. Adults will present with the worst sore throat of their life, plus minus on muffled voice. Typically nowhere near as drooly as kids. Adults will swallow their secretions better. You got a lot more room in there. They won't accumulate and pour out quite as quickly. But if you get that adult who's, got the fever, having trouble breathing, has a profound sore throat, you do need to be aware that it could be this. There's no way for you to know. But don't brush off a sore throat call, unless you do some history taking, where you know that they had, they've got active strep throat, that they don't have this, and it's, but again, there's a lot of information you don't know. If somebody's throat hurts bad enough and they can't breathe to the point where they're calling EMS, be very aware that it could be this, and their epiglottis is swelling due to the infection and blocking the glottic opening. Over here on the right, so this is a CT scan. Imagine you're looking at the patient from the front, and we've sort of sliced them, head to toe with the blade, running parallel to the shoulders. Not quite midway through, because if you look here, you see that's a little bit of the trachea. This is all the heart right there. So we're kind of in the middle of their body. And over here we got, this is their right lung, this is their left lung, and this is actually a Legionnaire's disease x-ray that's caused, there's a bacterial infection that's set up in the lungs. So you see, normal lung is supposed to look like all this over here. That's what normal looks like with this scan and these settings that were used to produce this image. So all this funkiness over here, there's bacteria growing in there. So all of that lung is unusable for gas exchange. And I can't tell you how big it is front to back, but if this extends all the way through the lung, front to back in this area, you see this person's lost, probably 2/3 of their entire right lung, potentially more. And you've got some consolidation over here, whether that's part of the infection or they've got some other process happening over there. I'm not sure. I'm not a radiologist, but this is bad news bears. This is why lower airway infections can cause shortness of breath, can cause hypoxemia. You're obviously not getting good airflow through here, but you're also not getting good gas exchange in the areas that are getting airflow due to the inflammation and accumulation of waste products and immune products in those areas. So how are we going to treat them? Supportive care is sort of the name of the game here. Oxygen as needed, BVM as needed. Treat them for the other things that might be going on. If they've got a bad pneumonia and they can't breathe and they're hypotensive, you want to treat their hypotension with a fluid bolus. But supportive care is going to be the name of the game. You're going to have your classic findings. You might have some diminished breath sounds. Over on the affected side, if it's a lower airway problem, so in that patient, you'd listen right to left, top to bottom. Your upper right might sound okay, maybe a little diminished. Your upper left sounds good. You get to those middle right, lower right areas, and you start hearing, you're probably going to hear some pretty coarse rhonchi from the accumulation of waste and mucus, pooling in your large airway tracts. You may also be hearing some crackles as you get some edema and some localized, alveolar destruction, fluid accumulation from the infectious process. And that epiglottitis image that I showed you, if you hear an adventitious breath sound, you're going to hear stridor. But again, by the time you hear the stridor, you're pretty late to the party. That person's airway is pretty well blocked off. It's going to be very difficult, even if, in the hospital, for them to manage it. So your usual history, position of comfort is really important. Epiglottitis, there's not a ton we can do pre-hospital, but keeping the patient calm and comfortable goes a long way. The more worked up and agitated they get, the worse the swelling gets, the faster they're going to be trying to breathe, which is going to make them feel more short of breath. So keeping them comfortable, typically sitting upright, especially your lower airway infections, if they've got some of the edema happening, keeping them upright can help. For severe distress, especially the epiglottitis patient, you might want to consider getting a paramedic because we can do an airway, through the neck below the level of the vocal cords if the patient's airway does become completely compromised. Your severe distress pneumonia patients, if they don't respond to just supplemental oxygen therapy, you pop the CPAP on them. They typically do really well. But this is that concept of supportive care, right? You're going to monitor, you're going to give them oxygen, you're going to assist their ventilation if needed, give them an IV and some fluids if they're hypotensive with any of this. If they've got an inhaler, yeah, you can use it. But, I'm going to make the point here that, not all dyspnea needs albuterol. This is sort of a pet peeve of mine. I mean, if they don't need it and you give it to them, it's probably not going to hurt. But I think it's a cop out. It's you not thinking about what's happening, right? If they're not having bronchospasm, if they're not wheezing, if it's not like a COPD exacerbation along with an acute infection or triggered by an acute infection, you might help them, but it's not really going to address the issue at hand. So if they've got one and they want to use it, that's fine. If you want to toss one at somebody, that's fine. But these are not primary bronchospastic presentations. So if you don't hear the wheezing, giving the albuterol is probably not going to accomplish anything. Watch them, get them to the hospital. I will put a note in, though, if you do suspect an epiglottitis or even a croup patient, we'll talk about that when we get to kids. you need to, the humidified oxygen will have a role here. Even a short course of humidified oxygen can help. Putting dry oxygen in can worsen the inflammation by drying all those mucosal membranes out. You can cause an inflammatory reaction, which can worsen their condition. So humidified oxygen does have a role in upper airway infection patients. All right, acute pulmonary edema. Um, these are pretty common patients. You talk to people in the hospital and they tell you, oh no, this is kind of rare. We don't see that much. You will see a ton of it pre-hospital, and if you do your job right, yeah, the hospital numbers will be low because we can turn these people around. I love a good CHF call. So what is acute pulmonary edema? As the name would suggest, it's a sudden accumulation of fluid in the lungs, right? You're getting edema, which is swelling caused by, fluid leaking out of the vasculature into the interstitial space happening in the lungs. So what happens is, we've got our alveoli here, and you can see, these are our capillaries, all these folks down here. And under normal circumstances, you can see, if this is the alveolar space, sort of everything below this line here, right? So this is the inside of the alveoli down here. I told you that gas diffuses best over a shorter distance, right? And that makes sense. It has to travel less, there's less material to go through, and it's more sensitive to the concentration gradient over a shorter distance. So we've got our capillary here. Note it's one cell thick. This is the nucleus of that epithelial cell. There's our capillary, little red blood cell right in there. So under normal circumstances, there's almost no space between, right? You've got one cell for the capillary and one cell for the alveoli. So that's it. It's got to make it through two cell membranes, and it's there. In pulmonary edema, that fluid leaks out of the capillaries and gets into this space here, and it starts to accumulate and build up such that you get this massive accumulation of fluid. And what that does is now that oxygen has to travel through a bunch of fluid to get into the airspace. Going the other direction. So that oxygen now has to travel through a bunch of fluid to get to that red blood cell and bind to it to get carried away. And the more distance there is, it may not look like much. Remember how small oxygen is. That's even if you only get, partial millimeters of space there, that is significant when you're an oxygen molecule. So you get fluid in that space, gas does not exchange well, and so you get a low oxygen saturation. As the disease progresses, not only will the fluid leave this, start to build up in here, it'll eventually start to leak into the alveoli themselves. And so now you get fluid pooling in here, and gas now has to go through all the fluid in the alveoli itself, then all the fluid in the membrane, and then into the capillary where it can get to a red blood cell. So that gets really hard to do, and you get even worse saturation. And then what ends up happening is you start to get fluid leaking out this way. Now it's getting in between all the alveoli, and you start building up, essentially a water level inside the lung, and everything below that level, you've got alveoli completely underwater. Water's heavy, it's going to compress on them, and all this here is going to snap shut just under the weight of all that fluid. And now you're not even getting gas down here. It's getting stopped here because that alveoli is closed. And so that person goes to take a breath in, and if they take a good forceful breath, they can drive the air down and force that alveoli open. But as they get tired and weak from doing that over and over again, those won't pop open. So that's where you start to get that fatigued effort, those ineffective respirations with this. And we're going to talk about how to fix this here in a second, but spoiler alert, it's CPAP, right? So if you've got all these guys underwater and this is all clamped down and stuck together, so you're getting absolutely no air. It's just your air is sort of bouncing off that sac, and you're just ventilating all this dead space over here. You pop CPAP on, now we have continuous airway pressure, right? Continuous positive airway pressure. So now you've got a constant pressure here pushing this way even without the patient breathing. So their breath in no longer has to pop that alveoli open. You can put enough pressure in here that you drive the water, you pop your alveoli open, water that's in this space now starts getting pushed back into the vasculature. So you open the alveoli, you displace this fluid, you displace this fluid, and now all that space is available for gas exchange again, and you're shortening that distance because the bigger we inflate this alveoli, think about like a balloon, it gets thinner as it gets stretched, right? You take a balloon out of a bag, you can't see through it at all, you blow it up to where it's super inflated and you can see light through it. Same thing happens here. We apply continuous pressure here and it's just like blowing up the balloon. That alveoli is going to stretch and get really, really thin, which will also facilitate getting gas across that membrane. But somebody suffering from acute pulmonary edema will have severe respiratory distress, and it can come on very quickly. Can happen after an MI, or if they've got just a chronically weak heart and they've taken in too much salt, or they stopped taking their water pill because it was a holiday and they wanted to hang out with their family and not have to go to the bathroom all the time. You can get trauma that causes direct damage to the lung tissue, and you just get normal swelling in there that can cause this. High altitudes can cause this. So anytime somebody's feeling short of breath, having chest pain, you want to check their SATs, check their lungs, make sure they're not filling up with fluid. You know, if the MI is massive or has been going on for a day or two and they're starting to suffer decreased cardiac function, you know, obviously that patient needs to go to a cath lab, and you may want to consider getting a paramedic in case the patient needs to get intubated or needs some cardiac support. You know, it can happen after a patient's been hypoxic. It can happen with a patient in septic shock. It's very anything that causes systemic inflammation can cause this pulmonary edema, this non-cardiogenic pulmonary edema. Chemical mediators cause vasodilation, causes fluid to leak out, and you get the same net effect. Certain toxic gases and high altitude. So these patients are going to be severely short of breath. Orthopnea, this is the biggie. It's on all your tests, and it's a dead giveaway in the field. And it's, you know, I can't lay down, or it woke me up from sleep and got better when I sat up, or I've had to sleep. You know, I've started adding more and more pillows. I used to only need one, and now I'm up to 5 pillows. Or I've started sleeping in the recliner because I can't breathe in my bed. You know, people who are tired all the time and they're not sure why, and you pop the pulse ox on them and they're satting, you know, in the 80s on room air. Typically, when you'll see that presentation with that low hypoxia and they notice how, or that low oxygen and they notice how tired they are, it's going to be after, reduced exercise capacity is a little bit misleading. It's reduced any activity capacity. Elderly people who tell you, I used to be able to walk to the mailbox just fine, or I would take my dog around the block, and now I can barely make it to the end of my driveway, or I'm winded when I get back with the mail. And it's, that's progressed just over a few days. You need to have this on your list. Start looking for other signs. The swollen ankles, are they on a pill that's supposed to get water out of their system? And then pulmonary rails are your crackles. By the time you hear crackles, you're late to the party. That patient's pretty darn sick. Probably the most common pulmonary edema call that you guys are going to go on is going to be classified as a congestive heart failure call. While CHF is a chronic condition, patients will suffer acute exacerbations of that, and we'll get into why they suffer those exacerbations when we get into the cardiology and shock lecture. But I just want you guys to know that CHF will result in pulmonary edema, and sort of the new reference to it is going to be SCAPE, which is severe crashing acute pulmonary edema. Can come after heart attack or other illness, and it is a pump failure. So the heart is unable to pump the blood effectively, and thus it backs up. And when it backs up, and I'll show you on the next slide what I mean by that, you get fluid in the lungs. People with hypertension, history of coronary artery disease, or arrhythmia are at risk for developing CHF over time. Your signs and symptoms are going to be typical of pulmonary edema. It gets worse when they exert themselves, because that causes the heart to have to work harder, and it's a failing pump, so the backup gets worse. It can come out of nowhere even after minimal exertion, because you get into a cycle, and we'll talk about that in cardiology and shock. Cough, but it's a very characteristic initially non-productive cough. So they cough, they don't bring anything up. You might be able to hear some crackling when they cough, sort of at the late stage when they're on the verge of decompensating. You'll get pink frothy sputum coming up, but that is super, super late. But if you get somebody who says they feel like they're drowning, they can't lay down flat, they're coughing, they're not bringing anything up, you need to be thinking CHF exacerbation. And then the cold sweats and the tachycardia are part of this vicious cycle that we'll talk about in cardiology. So the short version of how pump failure leads to this, right, is let's say that these cells in here are our lungs. And you have to use a little bit of an imagination here, because when we're coming into the lungs, this blood is going to be deoxygenated, right? And then the venous side is going to be oxygenated blood here. So you have your right heart on this side pumping blood into your pulmonary artery, gets down to the arterial. So this is a pulmonary capillary bed right here. And so this will be the pulmonary vein coming up to the left heart. And like we talked about in the anatomy and physiology lecture, under normal circumstances, fluid is supposed to move out of the lungs on the artery side due to the hydrostatic pressure, the force of the heart beating, and then it's supposed to get pulled back in on the venous side by the oncotic pressure, right? So there's low hydrostatic on the venous side. But when your pump is failing, right, when you've got a failure here, and it is unable to eject the blood out to the rest of the body, and you get backup, what you get is a pushback where you now have hydrostatic pressure on the venous end of the circuit. So now you end up with an elevated hydrostatic pressure, in the venous side, and it's unable to overcome, or it overcomes the oncotic pressure, so you end up pushing fluid out this way and out this way, and it is unable to come back in, right? So when you get fluid pushing out that's unable to come back in, it starts to accumulate in the lung space. So that is how a heart failure puts fluid into your lungs. We'll get into more of the details of this in cardiology and shock, but I just want you to understand how the fluid gets there during an acute CHF exacerbation. But guys, the care is simple. Get them oxygen. You can start by giving them more of it. And if that doesn't work, you need to help get it into the blood. And how do we do that? CPAP. Just bagging them won't really help because you still have to pop those alveoli open. So you're going to waste a ton of effort popping those alveoli open. So if you're going to bag them, put a PEEP valve on so you get the CPAP effect, or pop the CPAP on early so that they don't stop breathing, and actually manage the problem at hand so that the high flow oxygen can actually get into the bloodstream rather than just sitting in their dead space. If they're having chest pain with this and they're hypertensive, so a true CHF which is congestive heart failure exacerbation outside of an acute heart attack, right? This is a chronic problem that has flared up for them. The shortness of breath causes anxiety, which causes their heart to work even harder because now there's epinephrine in their system. They've already got a really weak, crappy heart, which is what started the shortness of breath in the first place. And you get caught in this vicious cycle, right? Where shortness of breath causes anxiety, which causes the heart to try to work harder, which makes it suck even more, which makes them more short of breath. And right, and you just see how this cycle starts to build. So they end up profoundly hypertensive because their body's just dumping epinephrine to try to keep them alive, right? Because it senses that they're not getting good blood flow, that they're not getting good oxygen. So it cranks up this epinephrine, clamps all these peripheral vessels down, which makes it harder for the heart to beat. We're going to talk about this when we get to the cardiac unit. But the net effect of all this is they're tachypnic, they're hypoxic, and they're hypertensive. So if they're having chest pain, nitroglycerin is an excellent drug to fix the problem at hand, and you guys can give it under your protocols if there's chest pain, because it is a true cardiac pain that's causing all this. So don't be afraid to use the nitroglycerin if they're having chest pain and they're hypertensive and you suspect pulmonary edema. Nitroglycerin and CPAP together have been shown to reduce hospital intubations of CHF exacerbations by up to 60%. There's a Canadian system and a Texas system that switched the EMS protocols to aggressive nitro and early CPAP and cut CHF related intubations in the hospital by 60%. Among patients brought in by EMS. So that's a very potent combo that you should fearlessly use in these patients, and keep them sitting up and comfortable. Try to not agitate them any further because you're just going to make things worse. You can try to assist them, but somebody who feels like they're drowning and you try to cover their face and breathe for them, you're not going to have a good time. If you feel like you need to bag them, but they're still conscious, try the CPAP first. You don't really want to give these people fluid. It's a fluid problem. There's a little bit more nuance to that, but it's beyond the scope of this class. But you do want access so that the hospital or a paramedic can promptly give medications to help this. And CPAP will turn. I cannot stress to you guys how effective CPAP is at managing this, and obviously get them to the hospital quickly. Moving on, COPD, chronic obstructive pulmonary disease, is both exactly what it sounds like and quite a bit more complicated than what it sounds like. It does occur fairly frequently in the population. I can guarantee you if you don't see this every shift, it'll certainly be every week, several times a month. This is a very common patient for us, whether the call is actually for an exacerbation or you have a patient who has a history of COPD. So what is it? It's important to understand that there are, I call them different flavors of COPD, and not all of them are the same, and how you manage them is not necessarily all the same. So the common trait between all of them is that you have an obstructed lung, as the name would imply. And where that obstruction typically occurs is you get it in the in the moderately sized air passages, right? So your bronchioles, and some of your smaller bronchi become obstructed, or you have inhibition of alveolar movement that obstructs the airflow in the lungs. So regardless of what the flavor of COPD is, you've got an inability of air to move freely through the lung space due to an issue within the lung tissue itself. So in contrast to CHF, which is obstructed flow due to the presence of fluid around the lung tissue, eventually it gets into the alveoli, but it's not a primary problem with the alveoli that's causing that. In COPD, your problem lies within the lung tissue itself, and it restricts the air flow. So you can see in this diagram here, you've got either swollen bronchiole right there, or you've got buildup of mucus and secretions in the airspace. So versus a normal one, that thick wall gives less diameter to the bronchiole, which is going to reduce your flow. Or you end up, you can still have your inflammation, your obstruction, but over here you end up with damaged alveoli that end up being really, really, really big at baseline. And part of how air is meant to ventilate through your lung space, right? You breathe in, and those alveoli are meant to distend, and that puts tension on them, so that when you exhale, those alveoli shrink back down and are actually able to clear the air out of them and get it back into the larger air passages. So if you have these permanently dilated alveoli that don't expand when you breathe in, when you breathe out, they don't contract back down. So you end up with air that just sits in here, that is unable to get itself back out. So we call that air trapping. And so with or without these obstructions up here, the flow of air is still going to be reduced, predominantly on its way out of the lung, due to a permanently dilated alveoli that's lost its structural integrity. So we're going to get to how the alveoli are damaged and how the inflammation occurs in those air passages in just a second. I want to briefly pop over into asthma because its pathology, or its pathophysiology, and how we treat and how we manage it is very, very similar to COPD. So in an asthma attack, you have a spasming of the muscles that surround your bronchioles. Back to our human anatomy chapter, I told you that your bronchioles are lined with this smooth muscle. So in asthma, that muscle spasms. The air tract itself becomes inflamed, and there's increased mucus production. So if you envision your airway passages getting smaller and filling with mucus, that sounds quite a bit like COPD. Our big difference here is that COPD, as the name implies, is a chronic condition, right? This patient's lungs are damaged at baseline. They live with this every day. They can have exacerbations where it gets worse, but they have chronic damage that impacts them every day, versus an asthmatic has normally functioning lungs on a normal day, and then they intermittently have attacks of their asthma. So they transiently present like a COPD case, and it's usually set off by an immunologic cascade. So there's a trigger, there's an allergen, or some kind of irritant to the lungs that causes this widespread spasming of the small muscles around their air passages. But once that starts, it is an obstructive pathology just like COPD. These patients don't typically have the alveolar distension damage. We're going to talk about that subset of COPD patients, but they certainly present exactly like the ones that have airway inflammation and mucus obstruction in those air passages. And this isn't to say that a COPD patient can't also have asthma. So you can have somebody who has a history of asthma who later develops COPD, and then when they go into respiratory distress, you sort of get the 2 for 1. These patients are really, really, really sick, really difficult to manage, but the management for both conditions, fortunately, is pretty darn similar. So if you treat one, you're going to end up treating the other. But when you're looking at a patient's history, you're taking your exams, it's important to note that asthma is the transient state. It's a chronic disease, but they're not always in a pathological state, versus COPD, they are chronically obstructed. And that's not so, obviously COPD exacerbation is bad, but an asthma attack can be fatal. And if you've got an asthma attack that will not relent, no matter what treatment you're throwing at it, we call that status asthmaticus. When you put the term status in front of a medical condition, it means that patient is stuck, right? That is their status. They're stuck in that state. Status epilepticus is a seizure that won't stop. Status asthmaticus is an asthma attack that won't stop. A true status asthmaticus patient is a critically ill patient, very likely to die without some high level, very rapid intervention. So you being able to recognize that is going to be extremely important. And we're going to get to that in the sort of the assessment and treatment section. So when you're looking at an asthma patient, you're going to hear wheezing. Now you'll also hear wheezing in your COPD patients. The difference with your asthmatics is they don't wheeze unless they're having an attack. Your COPDers might be a little wheezy at baseline, but during an exacerbation, they get worse. So your asthma patients typically have some kind of trigger that causes them to start wheezing. And we talk about both asthma and COPD being an air out problem, because the air gets trapped in the alveoli, right? When the diaphragm drops, the pressure in the chest drops. Air is able to suck in reasonably well because inhalation is an active process. You have a muscle pulling to make that happen. But when you have a ton of resistance against a passive process, which if you go back to the airway lecture, exhalation is our passive process, you don't have anything helping to make that happen, so the air gets stuck in the expiratory phase. We call it an air out problem, but left unchecked, left to run its course in what we would call the late stage of the disease, you start getting some inhalation problems, right? Your patients are fatigued, your patients have built up CO2, they're tired, their mental status is altered. Their hemodynamics may be compromised. They do end up fatiguing and being unable to get air in, but that is a late stage, and that requires some different management, as we'll talk about in the management section. Getting a good history on your asthma patients, whether it's from the patient or from a family member, is very, very important. Looking at their medications can be highly instructive. If they're only on albuterol, it doesn't guarantee you that you're going to have an easy time with it, but if you get the patient who is prescribed multiple medications, including steroids, or they have an EpiPen to help treat this, you know that you're dealing with a severe case on your hands, and you need to move with a sense of urgency, consider your paramedic backup, make sure the hospital knows what you've got. And if you ever have an asthma patient that tells you they have been intubated for their asthma before, it doesn't matter how they look when you get them, you need to be calling for a paramedic, and that hospital needs to be ready for airway management when you arrive, because that tells you that their body, when it gets into one of these asthma reactions, it can get bad enough that they end up needing a breathing tube and to be put on a ventilator. And these patients are extremely tough to manage when they're on the ventilator for reasons that are beyond the scope of this class, but you want to avoid intubating an asthmatic patient at all costs. They're very, very difficult on a ventilator. So now that you understand both the physiology of asthma and COPD, let's loop back to what causes the COPD. So you have to have insult to the lungs. In the vast majority of COPD cases, I'm not going to sit here and tell you all of them, but by and large, your COPD has a pretty clear causative agent. Cigarette smoking is the most common one, but you'll also see it in people who work heavy industry where they're exposed to smoke or dust or fumes in the line of their work for many hours a day over a period of many, many years. You end up getting similar lung damage like you would with a smoker. So the sort of different flavors of COPD, there's sort of two biggies. I split them into two branches. All right, so you've got your chronic bronchitis types, and you have your emphysema types. And you'll sometimes hear cute little monikers for these, like these are your pink puffers, and these are your blue bloaters. You'll never see those terms on the test, but they sort of give you the trope that you're looking for in these patients. So as a chronic bronchitis, the name would suggest, itis just means inflammation of. I know we often think about bronchitis as being an infection, but all itis means is inflammation. So these patients have chronic inflammation of their, bronchial tree, their main bronchi all the way down to their bronchioles, chronically inflamed. And so that's going to give you obstruction by narrowing that air passage. And because of that inflammation, you end up with poor management of secretions. You get excess mucus production, you get poor mucus clearance due to the destruction of, if you look at somebody's air passage, right? So I'm just going to draw, we'll call this alveoli over here. And you've got your little bronchiole coming off of those. There's little tiny hair-like projections that line your respiratory tract. We call them cilia, and their whole job is to pass mucus and dust and dirt and whatever else gets down into your lungs back up. So you end up making a ladder sort of back up to the trachea where you can then cough it out. So when you've got chronic, repetitive damage to those tracts and chronic inflammation, those cilia break down. They're damaged, they don't function anymore, which results in the inability to clear the mucus from the area. So you end up with swollen, narrow tubes full of mucus that cannot be cleared easily, and therein lies your obstruction. So due to that obstruction, these patients end up, they have more trouble getting air in than your emphysemic patients that we're gonna talk about here in just a second. So they're a little bit more prone to cyanosis due to hypoxia. So your chronic bronchitis patients will end up developing hypoxia as part of this due to inspiratory, blockage of those passages, hence the blue part of blue bloater. And then the bloater part comes from, there's a lot of cardiac side effects that are a result of this, and they end up having weight gain and edema, so they end up appearing sort of heavy set and bloated. And then we can hop over to our emphysemics, and we call them pink puffers. Your emphysemic types are where the damage is predominantly in the alveolar, sacs themselves. These are the patients that have the chronically distended alveoli. They become rigid instead of being flexible and springy and able to participate, help get the air out during exhalation. They're rock solid, inflexible. So these patients truly struggle to get air out of them. Their inspiratory flow is typically quite good unless they have, a combined type where they also have a chronic bronchitis or they have something else inhibiting their airflow. They'll still have the ciliary damage that prevents clearance of mucus, but they don't have the narrowed passages necessarily of the chronic bronchitis patients. So their inspiratory flows are usually good. They don't normally get hypoxemic quite as bad at baseline, but they end up having to use a lot of accessory muscles to help get the air out. They typically have higher respiratory rates, and they're sort of these side effects of their disease. They tend to lose weight. So these are your rail thin patients that have been smoking 2 to 3 packs a day for 20 or 30 years, and they tend to puff when they breathe. And there's a little bit of applying some CPAP to themselves to try to give a spring load to the alveoli, right? We talked about when you put a CPAP on somebody, we're trapping air inside of them to keep tension on the alveoli. So your chronic emphysema types who don't have that naturally will essentially try to CPAP themselves by pursing their lips and breathing out through pursed lips, which increases the pressure in their airway, and they can get a little more play in their alveolar membrane. So that's where you get the pink puffers. Don't get hypoxic quite like the chronic bronchitis blue bloaters do, and puff when they breathe in an effort to CPAP themselves. So I'm going to jump straight to the picture on this one, since we just talked about sort of the caricature of your emphysemic types. Told you rail thin, been smoking for a really long time. This is this guy right here. That's the look. Clearly not a blue bloater. He may well have, chronic bronchitis in addition to his emphysema, but this is what a patient with severe emphysema looks like. So what are they going to look like during an exacerbation, right? When somebody who has a chronic obstructive disease, suddenly worsens to the point where they're calling 911. They're having what we would call an exacerbation. So I talked about the emphysemic types that'll breathe through pursed lips in an effort to CPAP themselves. Your blue bloaters may start doing this during an exacerbation if they become hypoxic and they're trying to give every advantage they can to help them breathe. Remember, pursing your lips is essentially like applying CPAP, you know, at a lower pressure than what you would provide therapeutically, but it's your body's natural response to this type of trouble breathing is to purse the lips, provide a little bit of CPAP to help. Obviously, they're going to complain of shortness of breath. There's usually a steady worsening of symptoms, and that can be over a period of hours. It can be over a period of days. Some people will tell you, this has just been getting worse over the past 3 or 4 days. Nothing I do makes it better. The first day I used my inhaler 4 times. Now I've used it 8 times, since breakfast, and it's still not helping. Tightness in the chest and the barrel chested appearance go together. And that's from the lungs. When you can't get air out of them, they stay inflated, right? And every breath in potentially puts more air in that they can't get out. One of the best analogies I've heard to this, is if you have an auditorium that seats 100 people and you do one show, so we'll call that one breath, 100 people come in, they all watch the show, and then when it's over, you get 5 people who say, "No, I want to watch it again." But there's 100 tickets sold for the second show, so 100 people come into the auditorium. Now there's 105. And so, then you get, 5, 10, however many more people each time that decide they want to watch the show, right? And that represents things getting worse and worse and worse. You can see how the crowd in the auditorium is going to grow and exceed capacity. So the same thing happens with your lungs, right? Your patients keep breathing in, right? Because their brain is telling them, hey, you need to breathe. And if they can't get all of the air out, every breath in essentially stacks a little bit more, a little bit more, a little bit more. And so those lungs are going to stretch and stretch and stretch. You saw how the pig lungs looked with a ton of CPAP in the airway video. That's what a bad COPD exacerbation lung will look like. It'll be hyperinflated, unable to breathe out. We actually call that phenomenon, when they're doing that, you'll either hear it called air trapping, or I like calling it auto PEEP, right? Because how does PEEP work? When we put a PEEP valve on our BVM or we use the CPAP mask, we trap air in the lungs to maintain pressure. So if they're trapping air in their own lungs and it's building up pressure, that is PEEP. It's just coming from, their own structures not functioning rather than being applied therapeutically. So auto just means self and PEEP is PEEP. So those lungs will become physically overextended, which makes the chest feel very full, feel very tight. When they breathe out, the chest won't drop the way it's supposed to, and that's a very unpleasant feeling, and that can lend to their chest looking, bowed out far more than usual, either acutely or, if you look at this feller here, even, his belly, you can see his, he's got sort of a if you looked at him from the side, he's got a concave abdomen, right? So he's going to look sort of, this is his neck, and that's his head, there's his chest, and his belly's going to curve in. And that chest is bowed out relative to the rest of his body. And that's from his lungs being chronically overinflated. He's actually remolded his rib cage, and there's constantly air trapped in there. So that barrel-chested appearance can be acute, can be chronic, but it's a sign of either a severe chronic or severe acute condition, and it should catch your eye and alert you that this patient has a history, significant history, or is in significant trouble. And then the constant fatigue is because they're working hard to breathe. They're expending significantly more energy on every breath relative to you and me, and that is exhausting. And if their oxygen levels are low, that is exhausting. If CO2 levels get too high, that causes sort of fatigue, mental fogginess, lethargy. So all of those things will play together to result in a constantly tired or fatigued patient. So what are we going to do about these people? So, like I just referenced, sort of you got two issues at hand. Um, at baseline, these people are going to have more CO2 due to the impeded outflow that we've already talked about, um, which can, right, if their lungs are so full of gas that they're unable to get enough of it out, they're not going to be able to bring new gas in, which can then result in hypoxia. So both hypoxia and CO2 retention can result in a change in the level of consciousness. Um, they often find laying down to be difficult with regards to their breathing. Not quite as bad as your congestive heart failure patients, where when you lay them down, you're literally drowning them from the inside out. Your COPD patients, when you lay them flat, especially the blue bloater types, right? So let's say we're looking at a patient laying down from the side, and we'll call this, his leg. There's leg one, there's leg two, and they've got a big old belly like that, and then a chest, and a neck, and a head, right? So when they're laying down, all of this weight from their gut sinks down into their belly, and it's going to push their organs up into their diaphragm, which makes their diaphragm have to displace all of those, right? So let's put your diaphragm right here, and we'll call your lungs right there and right there. Obviously, I'm giving you a lot of different perspectives because you wouldn't be able to see both lungs in this view, but I think you'll still be able to get the idea, right? So when they lay down and their stomach pushes down and it displaces stomach contents up into the diaphragm, now for them to breathe, that diaphragm has to push those out of the way in order to come down, and that is exhausting. So if they're already tired and they're already struggling, that will make things significantly harder for them. These patients will tell you that they've used their inhaler more than they're supposed to, or more frequently than they usually have to, and things still aren't working. So if they have not given the max number of doses per your protocol, Mr. Camp's going to go over, what all that looks like in lab. You want to make sure you help them use it. The first line, the number one thing we can do for these patients, you can put them on oxygen, but that's only going to help them if their oxygen level is low and you're still not treating the actual problem. Supplying them with the medication from the inhaler, what you're doing is those drugs, like albuterol, is a beta agonist. We'll talk about what that means when we get to pharmacology. But beta receptors, when they're activated, cause smooth muscle in the bronchial tree, they cause smooth muscle to dilate, and the vasculature causes it to contract. But in the respiratory tree, albuterol and all beta acting medications cause that smooth muscle to relax and dilate. So your first line is going to be to administer an inhaled beta agonist. Why inhaled? Because that gets it right to where you want it to go. You're putting that drug into the bronchial tree, putting it right on the tissue that you're wanting to affect. It's very, very fast acting in that way, and you don't get a ton of crossover effects. Some of it will get absorbed, some of it will go into the bloodstream. So, it is not uncommon for you to see an increased heart rate in patients that are using an inhaler or someone that you're nebulizing an albuterol treatment for. So you just want to be on the lookout, for overuse and the side effects that go along with that. And the big one is tachycardia. Some people might report a little bit of, chest pain or anxiety, but that will resolve once their breathing gets easier. You just want to be on the lookout for extreme derangements with the heart rate. And if you're ever on the fence about whether to give it or not, go ahead and get medical control on the horn. Now, I'm sure some of you have probably spotted the issue with this. If a patient is really, really, really sick, right, they're at sort of that end stage, end of the road, I told you they get so tired or so obstructed they can't get air in. Well, if they can't get air in, how are they going to get an inhaled medication down into their bronchial tree? They won't. They can't. So what do? We can give them a beta-acting medication, and if we can get it into their bloodstream, it'll make its way into that muscle tissue via the bloodstream. So the injectable beta-acting medication that you guys have available to you is epinephrine. So Mr. Camp will talk about how to give it. He'll go over dosing with you. I'm just here to tell you that in the event that you're facing a severe case that is not responding to inhaled beta agonist, or who's unable to take a breath in any meaningful volume, that you can administer a beta acting medication intramuscularly, but it is a second line, meaning you have to try to give them an inhaled one first, because injecting epinephrine comes with a lot more of those cardiac side effects, a lot more of the hemodynamic effects. You're going to get vascular action, you're going to get cardiac action, in addition to the bronchial action that we desire. So it is for persistent, which means not ending. Refractory means you've tried to treat it with something else and it either came back or it didn't go away. Wheezing and distress. So when you listen to breath sounds, wheezing is the hallmark of what we would call bronchoconstriction, right? When you've got really tight bronchioles that are clamped down, that's going to generate wheezing, which is an expiratory whistling sound that'll be more prominent lower, in your lower middle lung fields. The other whistling sound you have with breath sounds is stridor, but that is an upper airway heard predominantly in the throat, and it's typically associated with inspiration. So wheezing is an expiratory sort of musical whistle, more prominent in the lower airway. So if you've got somebody who's fatigued, who's exhausted, who you look at and you're like, if we don't do something, they're going to die, and you've tried albuterol and it's not working and they're still wheezing, that's when you'd want to hit them with the epinephrine. Not before that. Don't use the epi first. But there is room for it, for you all to administer it, and it's actually in your protocols here for the state of Tennessee. So keep that in the back of your mind when you've thrown albuterol at somebody and they're not getting better. And obviously you need to get them to the hospital quickly, because if they need to get intubated or need some more potent medications or delivery methods, that's where they're going to be able to get that. As a summary of the management of both COPD and asthma, anybody in respiratory distress, it's a good idea to initially apply supplemental oxygen. If you can get the pulse ox on them and their saturation is fine, you can always turn it down later, but you're better to get it on early, especially if you're working with a paramedic who may end up intubating a patient. The longer they're on supplemental oxygen prior to the intubation attempt, the more time they will have to get the tube in before the patient desaturates. So it's always a good idea on respiratory distress patients to at least start them on some oxygen. Nasal cannula at 4 is my preferred, but there's certainly no law that says you have to do that. We are steering clear of the non-rebreathers as the go-to, at least at first, unless there's obvious, cyanosis, severe distress where you're going to be escalating your care imminently. Couple reasons for that. One, hyperoxygenation is harmful. And 2, it's hard to get a good assessment of your patient with a non-rebreather running wide open. It's very noisy. It obscures the patient's face and mouth, making them hard to hear. It's hard to hear breath sounds. So slapping the non-rebreather on all of your trouble breathing patients needs to get out of y'all's repertoire. Let's say you assess your patient, you see the increased work of breathing, you note a quick inspiration, a prolonged expiratory phase, you can hear some wheezing, history of COPD or a history of asthma. It's reasonable at that point to go ahead and administer an albuterol treatment via nebulizer, and Mr. Camp will show you the right way to do that. But inhaled beta agonist is definitely your first line treatment for these patients, and the beta agonist used in the United States most broadly is going to be albuterol. The big caveat there is it does require good tidal volume, so pay attention to your technique. When you do it, there's a way to do it right, and Mr. Camp will be more than happy to show that to you. Be sure to try to reassure your patient while you're doing it. If you can slow that breath down, they'll be able to get more in. They'll have more time for the exhale. Everything will get better if you're able to slow that rate down. Now, let's say their tidal volumes are barely moving their chest, not moving their chest at all. Their chest is stiff. They're telling you they're not getting any air. Their lungs are getting really, really quiet, right? Let's say you've got somebody who was wheezing and now you can't hear any air moving. That person's starting to, level of consciousness is starting to decline. Their O2 sats are starting to go down. The big one is coming. Death is imminent. Severe status asthmaticus or a COPD exacerbation that's reached its terminal phase. Intramuscular epinephrine is the drug of choice. The inhaled medications will not reach the target cells down in the distal respiratory tree. Administering epinephrine intramuscularly gets it into the bloodstream very quickly. So as long as your patient still has a pulse and that heart is still working, it will distribute in under a minute all the way throughout the body, and will exert the beta effects on the smooth muscle in the bronchial tree, causing bronchodilation. Along with that, it means your heart's also going to get affected. It's going to speed up. It's going to beat harder. Your blood vessels are going to clamp down tighter. So especially in your older patients, your cardiac patients, this does come with a certain degree of risk. However, the literature is pretty clear that you're under 50 crowd, certainly you're under 35 to 30 crowd. Very, very, very low incidence of adverse effects from giving epinephrine. Certainly a much higher incidence of adverse effects from not breathing due to the condition that's prompting you to give the epinephrine. So patient selection is very important. But if the alternative is your patient stops breathing, it's probably in their best interest to go ahead and get that medication. And then you do want to start an IV and consider giving IV fluids, particularly if they are hypotensive to that big distended chest. The auto PEEP, you can get the same hemodynamic compromise from auto PEEP that you can, from medically initiated PEEP. So if you are starting to see that hemodynamic compromise, some tachycardia, some hypotension, it's a good idea to start that line and go ahead and get some fluids going. And you certainly want to have one in place regardless on these patients. And then some sort of clinical pearls associated with asthma. in particular. It's a rolling reaction that can progress very quickly, whereas COPD will creep up on people and they know they've got it, they know what's happening, they can feel it coming. Your asthma attacks are going to present very similarly to an anaphylactic reaction, sort of on the time scale, where they will be fine 1 minute and then 2 minutes, 5 minutes later, they can't breathe at all. They're circling the drain. So you do need to be constantly watching these patients. And this is something where putting your end-tidal CO2 monitor on them, especially if you're working with a paramedic and it can hook up to your monitor, you want to go ahead and get that on, because then you can look at the monitor and it will give you a true respiratory rate, not the garbage one that the cardiac leads give you, but a true respiratory rate, as well as their CO2 number, which is significant to the medic as far as gauging their perfusion and respiratory efficacy. If you do assist an asthmatic with their breathing, it's important to remember the air out being the problem. So you want to give a nice quick breath in, perhaps quicker even than you would give your normal breath. Then you want to give a nice long expiratory phase, right? You're going to want to try to coach these patients through it as best. They're going to be very tired. They may not like it, but they will probably be more compliant than somebody who's with it that you're trying to bag. So you want to coach them through this process. You've got to get that rate down to give them time to exhale. So good, quick breath in, and then let them breathe out. And their CO2 may be off the chart, right? This whole target 35 to 45 thing is true under general circumstances. However, in these patients, that number may be significantly higher, and you do not need to speed your rate up. You will end up making it worse because you're going to prevent any CO2 from getting out as you speed your rate up and shed expiratory time. If they're hypoxic, you want to use 100% FiO2. Adding PEEP, you can put a CPAP on somebody suffering from asthma, suffering from COPD, and it may help. Right? I said, early, middle phase of the exacerbation, they'll purse their lips to try to give themselves a little PEEP to put a little tension on those alveoli so they can spring back and help them breathe out. But as you get later and later and they've trapped more and more and more air, you don't want to trap anything else. And in a lot of cases, the pressure you're setting your PEEP valve to is less than the pressure being maintained by their own lungs. So you're really not even doing anything. So if you're having to bag one of these patients, stacking a ton of PEEP on them is, at best case, not going to do anything. Worst case, you could actually worsen the problem by doing it. So oxygenation issues in these patients should be addressed primarily with high flow oxygen. CPAP early on is worth a try, but you need to be aware of the limitations of that. If it works, that's great. You can hook your nebulizers right up to it, decrease the work of breathing while you're giving them a nebulizer, stent those alveoli open, which will let the air flow deeper into those parts of the lungs, will help relieve the bronchospasm. That's excellent. But you've got to keep an eye on them, because if they're air trapping, you could run into trouble pretty quickly trying to use PEEP on these patients. Treat kids exactly the same way. Asthma is I don't want to say pretty common in kids, but it's a childhood illness, right? The diagnosis is usually made in childhood. It can be exercise induced. It can be environmentally induced. A couple considerations: they're not going to like things on their face. You may have to do blow-by treatments. Try to get a parent to maybe hold the nebulizer mask if you can. And if you do get that kid who's in status where their mental status is affected, they're starting to desaturate, they're not getting chest rise with their breaths. JBL wants you to give them oxygen and transport immediately. They can still get the albuterol and the epinephrine. because not breathing will kill your patient, far more quickly than either of these will, and those two will most certainly help your patient if they are in status. And again, I cannot overstate how tired these patients get. So you've got to keep an eye on them. Stay aggressive. It's so much easier to get out in front of respiratory failure than to try to dig somebody out of it. Because once they stop breathing, they could lose consciousness. Their hemodynamics are going to be severely compromised if you have to switch them to positive pressure ventilation, and they're already profoundly hyperinflated. So you want to get aggressive early with your albuterol treatments. That epinephrine, if you see that bad news is coming your way, don't wait for them to completely tucker out and stop, because then that's a whole other world of issues that's a lot harder to fix. Or you want to get your paramedic involved early. If you don't have one riding with you, you want to call for it. Call for the wing if you're out in the sticks somewhere. But remember, you guys are now advanced EMTs. So you are, I call you ALS light. You have the ability to do some advanced thinking, some advanced diagnostics, and some advanced treatments on your own. So take ownership of that and take care of your patients. Always stick to your local protocols. But Tennessee, lets you give nebulizer treatments. If the patient's not prescribed them, you can give that epinephrine. So be aware of what you can do and use it if your patient needs it. So here's a list, if you're interested, of common inhalers and what conditions they treat. I'm not testing you on this. This is more if you're interested. You always want to use what the patient's prescribed, but if it's expired or doesn't have a spacer or looks really old and beat up, been exposed to extreme temperatures, you just go ahead and use your own equipment. Make sure you get a good count of how many times they've used it before you've given it, because your protocol may restrict you to a total number of doses without consulting medical control. And just some more general use instructions for the inhalers. You always want to repeat vitals anytime you do any kind of treatment for your patient. And things you're looking out for: the tachycardia, the hypertension. A little bit of that is to be expected. Any profound deviation from where they started, you want to exercise caution. Again, when in doubt, get a doc on the phone. They'll guide your next move. And as always, transport to the closest appropriate hospital. Quick note on the fluids. You want to be careful with these. I would always err on the side of withholding if you're in doubt. But you really got to make sure that what you're dealing with is COPD or asthma, not congestive heart failure. And you want to make sure there's no underlying heart history, because if you blast a CHF exacerbation with fluid, you've made it worse. If their heart can't handle a big fluid bolus, you'll make it worse. But your septic patients with a pneumonia who are having trouble breathing and they're tachycardic and their blood pressure is a little dicey, some fluids are excellent. Your asthmatics who are tachycardic, may not be hypotensive yet, but that tachycardia is getting worse. That blood pressure is starting to dip down. Fluids are an excellent choice in these patients, but you always, always, always want to check your breath sounds before and after, again, listening for those crackles, and watch your SpO2 monitor to make sure it doesn't start to take a dip during or immediately after a fluid bolus. All right, on to anaphylaxis. This is the big ugly brother of an allergic reaction. There is no actual textbook definition of anaphylaxis. There's a couple consensus definitions that are used. For you all, the two criteria that I want you guys to keep in mind are either 2+ organ systems involved. So that can be skin and GI tract, that can be skin and respiratory, that can be cardiac and GI. That's a little bit more of a nuanced distinction, but if you think that both of those are related to an allergen exposure, it's reasonable to jump on it like it's anaphylaxis. Or any airway involvement. So, I mean, it could be one of your two organ systems, right? They could be having their throat closing and a rash, and that would meet both of my criteria here. But anything with an airway involvement, right? I feel like my throat is closing. I feel like my tongue is getting too big. I feel like my lips are going to swell shut. Those are all indications for you to jump on the anaphylaxis side of the equation versus the allergic reaction. So a couple things that happen in anaphylaxis: your airway swells, you get profound systemic vasodilation. We'll talk about why that happens later in the semester. So they can't breathe, their blood pressure tanks. Those two things, independently or together, can, and I would say will, lead to death if left untreated. So, the sort of secondary sign that we usually associate with an allergy is widespread itching with a rash, and then the breath sounds. If their throat is not affected, or if it is but it's not stridorous yet, and you listen to their lungs, you may hear some wheezing, and that wheezing comes from inflammation in the bronchial tree, just like an asthma exacerbation. It causes inflammation, and that muscle actually spasms shut and starts dumping a bunch of mucus into the air passage. So it looks and sounds, and to your patient feels exactly like an asthma attack. So our treatment is not surprisingly similar. The big difference is if you suspect anaphylaxis, you are going to do epi first in an anaphylactic patient, right? Because the issue is not just in the respiratory tract, it is everywhere. And epinephrine actually perfectly treats every single thing that's happening, right? It causes your vasculature to constrict, it causes your heart to beat harder, it causes your bronchial tree to relax. So it addresses every single facet of what's going to kill your patient, versus in asthma, it is isolated to the lung, so it's reasonable to try to do an inhaled med first to target just the affected organ system. But in anaphylaxis, it's multi-organ, it's systemic by definition, so you want to use a systemic medication, and that is going to be your epinephrine in these patients. It is reasonable to start an albuterol treatment after you've given epinephrine, because it's reasonable to focus on the lungs and the respiratory tract, because that's likely to kill your patient the fastest if you don't fix it. But you always want to start an epinephrine if you suspect anaphylaxis. Typically, these will occur within 30 minutes. The one sort of exception to this rule is ingested allergens. So I'm not talking necessarily about like the shrimp. A lot of the shellfish allergies are contact allergies, so you'll get the rash and the swelling, in and around the mouth, which is that's an airway nightmare that needs to be dealt with very quickly. But some people have allergies that aren't triggered until the food is actually, into their digestive tract, out of the stomach. So, I mean, it can be hours later. So don't rule out an allergic reaction if you go on the call that's, severe abdominal pain, nausea, vomiting, and you notice a rash, or they tell you, my throat's really scratchy and I've got a bad stomach ache and I can't stop vomiting. Dig back in their history, several hours. What have they eaten today? What did they eat for dinner last night? because you can have allergies crop up secondary to that. But any anaphylactic reaction, so anything that's two or more organ systems or anything involving airway or breathing in response to an allergen, is a true critical emergency that you need to treat promptly and aggressively. So sort of your algorithm for that, not too much new from basic, right? Get rid of whatever's causing it, whether it's a bee stinger or food, or if it's something in the air, remove the patient. Like if they're allergic to peanuts and didn't know it, went to Texas Roadhouse, whatever the case may be, you got to get them out of there, or you're not going to be able to fix anything. Priority is going to be airway, but our best treatment for that is actually a medication, right? So if your patient needs suction, you need to do that, but epinephrine should be hot on the heels of opening and suctioning the airway, because if you try to ventilate them into a closed airway, you're not doing them any good. You have to treat the underlying problem. Depending on the number of hands, it's reasonable to put the supplemental oxygen on early so that you buy yourself some time before they desat. If they do stop breathing, you can assist them as needed, but somebody on the squad, right, well, kind of all of this other stuff is going on, somebody has got to be getting your epinephrine out. Like we talked on the last side, anaphylaxis is bronchoconstrictive. Just like asthma, it's vasodilatory, it's cardiac suppressive. All of these things, literally every one of those things, is very, very effectively treated by epinephrine. So, all these other things you're doing are treating symptoms, but you're not going to be able to fix anything until you reverse the reaction with your epinephrine. Okay, on to pneumothorax. This is pretty straightforward because there's no difference in what you guys can do. You can't do anything about this. Can be medical, can be trauma. So if you get a penetrating injury to the chest, very, very high risk for pneumothorax. You want to be on the lookout for it. Blunt injury to the chest, your MVAs, if they hit the steering wheel, right? If you get somebody ejected from a bike and they land on their chest, if somebody gets punched in the chest really hard, kicked in the chest, you need to be very aware the risk of them developing a pneumothorax. And a lot of these can happen too. That's why you will always want to check the back on your patient. Do they have a wound? Do they have an injury pattern on their posterior thorax? Because you can cause a pneumothorax just as easily from the back as you can from the front. So what is a pneumothorax? So it's air that gets inside the chest, sort of in between the chest wall and the lung. That's not where air is supposed to be. That's where your lung lives. Right? So every time your patient exhales, right, their lung shrinks back down and air will get pulled in through the wound and will start to accumulate in here, and that can build up pressure, and as the pressure increases, it pushes on that lung and squishes it down, which means it can't expand as much as it did, and that will lead to shortness of breath, desaturation. You can eventually build up so much pressure that you start to compress, right? Those, we talked about the subclavian vessels that live up here, those will start to get compressed. You'll actually start to physically compress the heart, which makes it not be able to beat quite as effectively, and then you'll start driving the heart into the lung on the other side, which makes that lung not work as well. And when you start getting the hemodynamic effects, or your patient begins to decompensate from this, we call it a tension pneumothorax, because the tension inside the chest is, you have tension in the chest. Your pneumothorax has now created tension within the chest. Everything is pushed together. So there's tension that lives there. That is a critical, life-threatening emergency that you all are unable to fix. So that'll take a paramedic or your friendly neighborhood trauma center to deal with that. But you all do have a way to help these patients. We'll get to that in just a few minutes. So things that predispose medical patients to getting a pneumothorax. So people who have chronic lung problems where the lungs are weak, where they've got a chronic disease state in them, whole host of reasons that predispose them to pneumothoraces, but it should put it on your differential, right? If you're treating an emphysemic patient, you're treating an asthmatic patient, and they're complaining of shortness of breath, but you're not hearing the wheezing. It doesn't sound like a COPD exacerbation. You really want to listen for the differential breath sounds from one side to the other. You want to be on the lookout for signs of tension building inside the chest because it could be a pneumothorax. Your other at-risk population are your really tall, really thin, typically male patients, and that's just sort of surface area, volume issue. The pressure in the lung versus its surface area predisposes them to end up with a space in between their lung and their chest wall. And if there's damage to the lung, you'll get air accumulating in that space. So tall, thin male patients, they can be young, they can be athletic, no other medical problems, sudden onset shortness of breath. You always want to ask, have you been coughing recently? Do you have a cold? Or it could be a simple, piece of dust got down their throat or a little piece of food and they coughed once or twice and now super short of breath, a little bit of chest pain. Pneumothorax needs to be high up on your differential there. By nature of this, they typically come on suddenly. Whatever event is going to cause it very quickly, right? So they'll be fine, and then all of a sudden they couldn't breathe. They're complaining of chest pain that is non-cardiac, right? It's not focused on the left side. It's not going to the jaw. It's not going to the arm. It doesn't feel like a pressure. It's more of a sharp, diffuse pain on one side of the chest. Again, that should perk your ears up, and you should be looking for that pneumothorax. We always teach that the breath sounds will be absent or decreased. It's hard in the hospital in a quiet room to appreciate, one side being diminished to the other, especially in any kind of a thin patient where you can hear across the chest. By the time, if you wait to hear absent breath sounds before you make the call that that's what this is, or start treating like that's what it is, that ship has sailed, right? If they have absent breath sounds, that pneumo has most likely tensioned, and you've got a whole host of other issues. So don't rely on that in the real world. If you see absent or diminished on one side on a test, it is a pneumothorax, or a pleural effusion, and we'll talk about sort of your buzzwords on that one. But some of the signs and symptoms, especially early on, they could be a little pale, a little diaphoretic, they'll be breathing a little bit faster, but otherwise they're conscious, alert, oriented, talking to you, but they'll tell you, all of a sudden it got hard to breathe, I've got a little bit of pain in my chest, and I started sweating a little bit, and that's pneumothorax until proven otherwise. In the severe state, you're going to get all your usual signs of respiratory failure that goes with not getting enough oxygen in, not getting enough CO2 out. So confusion, altered mental status, cyanosis, increased heart rate, because that's one of your body's compensatory mechanisms is, the blood's not carrying enough oxygen, I better cycle it faster. So you can see some tachycardia, one-sided breath sounds, hyperresonance to percussion. You'll have to ask Mr. Camp to show you that in lab if he is so inclined. That's a little bit of an old and outdated skill. I still think it's pretty useful, but by and large, it's gone out of style, out of practice in modern EMS. So subcutaneous emphysema, this is air that's building up under the skin, right? So you push on it and it feels like you're pushing into a bowl of Rice Krispies. You're pushing down into a Rice Krispie treat is what sub-Q emphysema feels like. And, that could be if a penetrating wound has created a track where air can get, out of the chest and under the skin. But you'll sometimes see it even with a, non-traumatic or a closed pneumothorax if it is traumatic. You'll see air start to creep up into the neck. It can get up into the shoulder, and in really, really severe cases, it'll actually run down their arm. And then sort of the last domino to fall is tracheal deviation, right? So that's going to be look at their neck, and their trachea is going to be cocked off to one side. And by the time that takes a tremendous amount of pressure inside the chest. Very high likelihood that if you see that, your patient is in cardiac arrest or peri-arrest, and will remain that way until the pneumothorax is treated. And again, if you do find any of these severe symptoms, it's critical that you either get them to a hospital as quickly as possible, even if it's not a trauma center. This is sort of bread and butter. Any EM doc should be able to do the initial care for this, or you get a paramedic involved, and they can stick a big old needle or a scalpel in there to relieve some of that pressure. So how do we manage a pneumothorax? All your basics still apply, right? You want to make sure they have a patent airway. You want to support their breathing. Positive pressure ventilation is going to be your friend here, right? There's a whole bunch of pressure inside the chest. They're having trouble expanding that lung. You do want to bag them gently, and you do not want to apply a bunch of PEEP, right? Because PEEP's going to prevent air from getting back out. So you stand to trap more air in the chest. So you want to bag them gently so you don't cram more air in. You do not want to use PEEP. This is one of the few cases where I'm going to tell you no PEEP, because you want that air to be able to get out as efficiently as possible. And then just keep a close eye on them for decompensation, signs of a severe tension, and high flow diesel. That's about it. Next up on our respiratory disaster sampler platter is the pleural effusion. It's physiologically, it's very similar to a pneumothorax, but instead of air accumulating in the pleural space, you have fluid. You have pleural fluid that accumulates and pushes the lung away from the chest wall and limits its expansion. So it's going to present fairly similarly: shortness of breath, anxious, tachycardic, possibly some non-cardiac, some pleuritic chest pain. The root cause of this, though, is often either an infection or a tumor, something that induces some local inflammation. Right, you guys all know, like if you get a small cut, you get that release of the clear serous fluid coming out of it. Same thing in the lungs. If there's an infection or some other form of irritation, tumor is the big common one. That fluid that seeps out from that damaged tissue will accumulate in the space and put pressure on the lung. There's not a whole lot we can do about it. You give them oxygen, you BVM them if they need it, but otherwise it's a monitor and transport type of situation. Obviously, the fluid needs to come out, but that is beyond y'all's scope, so support the ABCs and get into the hospital. Pulmonary embolism. This is sort of the big, scary one, that'll drop pretty unsuspecting, otherwise young, healthy, or in a lot of cases not young and healthy, but that sudden collapse, if it's not caused by a heart attack, pulmonary embolism is usually a good culprit. So a blood clot's a thrombus, and when it breaks free, that's a embolus. So a roaming thrombus is an embolus. And when that clot nests in the pulmonary artery and blocks blood from getting into the lungs, you obviously, if there's no blood going into the lungs, it's not able to pick up oxygen and go back into systemic circulation. So the more area affected within the lung, the bigger the problem that's going to pose for your patient. So it causes that ventilation perfusion mismatch that I talked a little bit about in airway, right? So the lung, you'll have clear lung sounds, there'll be good chest rise, you'll hear air moving all the way throughout the lung, but there's no blood coming past those air spaces to pick up that oxygen and offload their CO2. So if your clot blocks, the entire pulmonary artery, going to one of your lungs, you're essentially down an entire lung. So you're on a one lung system, which is not sustainable in most people. There's some other cytokine and some signaling issues that happen that make this significantly more problematic than, in a surgical setting where they'll clamp one of these arteries. The big nasty one that you'll sometimes hear talked about is the saddle embolus, and that's where you get a clot that nests right here at the bifurcation in between the right and left pulmonary artery. Right, so if you get a big clot here, you're now blocking flow going to both lungs, which is obviously really, really, really bad news. That's the sort of the dead right there, the classic, like he was fine and then just all of a sudden he collapsed. Never appears in a shockable rhythm, doesn't respond to any of your CPR treatments. Culprit is frequently a saddle pulmonary embolus. So there's a couple things that predispose your patient to a pulmonary embolus. And it's the sort of the test version you might see is Virchow's triad. And the three factors are you have to have some kind of insult to the blood vessel, so an endothelial injury, and that can be diabetes, high blood pressure, something that causes inflammation and instability in the lining of the blood vessels. Then hypercoagulability is something that predisposes them to forming blood clots at a higher, more likely to form them than a normal person. Causes for this, and the one that FISDAP and National Registry really likes to give you is somebody taking an estrogen-based birth control pill will cause a state of hypercoagulability. Patients who have sustained an injury in the immediate post-injury period, right when the body is trying to clot off from an injury, there's all kinds of coagulation factors in circulation that makes them hypercoagulable. There's a lot of sort of other diseases that end up triggering a hypercoagulable state. So, at this level, you guys need to think somebody who has some other medical condition, something else significant currently or recently happening in their medical history, or that test favorite, taking an estrogen birth control medication, and then slow blood flow in, it doesn't even have to be a lower extremity. Most of these come from the leg, but a low flow state, right? A stagnant state. The classic again, test question. And also, I mean, there's a fair number of these that do occur in the real world. The long flights, right? If somebody's been on a flight in excess of 6 hours and they haven't gotten up, walked around, done anything to move the muscles in their legs, blood will pool in the venous side. And if there's damage to the lining of the blood vessels, that gives a site. There's a little micro injury that will start the clotting cascade. And if they're hypercoagulable, that clotting cascade runs rampant, gets a little more aggressive than it should. And because the blood isn't flowing, that clot is able to sit and form. And when it sits and forms, you get a big, gigantic plug that ends up sitting, in the big vein in your calf. And eventually, a little piece of that might, because your body naturally degrades blood clots, right? Little blood clots form all the time, day in, day out, and everybody's body are getting little micro injuries, blood clots form. Your body does a really good job of breaking those apart. But, when the three conditions here are met, you end up getting one gigantic clot, and your body will attempt to break it down, and it can break a little piece off, or the blood flow going past, or movement, right? Somebody massages their calf, gets up, walks around, but it's already been too long, and that's when you get a little piece that breaks off, right? And it's that little piece that travels up the vein, into the iliac, into the vena cava, right? So here we're coming up the vena cava, into the right heart, out the right ventricle, into your pulmonary arteries. And that is how we get pulmonary embolisms. These statistics are a little presumptive, I think, because we don't know how frequently people get small pulmonary emboli that their body just breaks down and deals with on their own. But I mean, there's a small proportion of diagnosed pulmonary emboli. 10% of diagnosed pulmonary emboli result in death, and 5% are the instantaneously fatal. These are particularly tough because they'll strike younger people, and they just don't respond to resuscitation, because no matter what you do, you're not getting effective blood flow past the clot into the lungs, so you're not able to deliver any oxygen to the heart, which means all the CPR in the world isn't going to do you any good. So here's a big list of your risk factors. You don't need me to read them off. You can pause it, take a look at them if you want. Signs and symptoms: sudden onset shortness of breath, sudden onset of pleuritic chest pain. It's not always clear that this is pleuritic chest pain, but it's almost always reported as a sharp stabbing pain. Can be in the middle of their chest. It could be lateralized. It depends on where that clot ends up going, but it's sudden onset, right? They get pain and shortness of breath all of a sudden. Hemoptysis is coughing up blood. Cyanosis is turning blue. Tachypnea, breathing fast, and they drop their O2 set. And all of this happens, I mean, quickly, right? They'll be like, I was fine, and then all of a sudden I couldn't breathe, my chest hurt. Be wary of the PE. And man, there's just not a lot you can do for them. Normally, cardiac arrest, we're finding more and more that the stay in play is probably better for our patients. However, if you think it's a pulmonary embolism, right, either based on their history or what a bystander tells you they said before they went down, or a family member is able to tell you, this is one of the few times where scooping and screwing on a cardiac arrest is in the best interest of the patient. You can initiate CPR if they're pulseless and apneic, but remember, if it was a big enough clot to drop them, the likelihood of you being able to get blood past it to meaningfully oxygenate their myocardium is slim. So you got to have a plan to do that on the road, which means you're going to want a mechanical CPR device before you leave. So it's the logistics with the suspected pulmonary embolism get complicated if you want your patient to have a good outcome. But scoop and screw mechanical CPR is definitely the way to go. If they're not in cardiac arrest, you're still going to treat the ABCs. These patients, if they're calling 911 for it and they're desaturating, will typically need all the oxygen you can give them. One of the few cases where I think a non-rebreather is reasonable, and if that's not enough, give them a nasal cannula and a non-rebreather. You can CPAP these patients, but you've got to keep an eye on their blood pressure because a big pulmonary embolism induces a lot of strain on the right heart, and the right heart does not tolerate increases in transthoracic pressure all that well. So if you use CPAP on these patients to fix their hypoxemia, you want to stay in that 5 to 7 range and just keep an eye on the blood pressure. And if it starts to tank, you got to take it off and try to oxygenate them, by flowing super high concentrations. And physiologically, that should make sense, is the right thing to do anyway, because their hypoxemia is not caused by alveolar dysfunction, right? This is a circulatory issue, and no amount of PEEP, you're going to get the usual bump from PEEP that you get just by re-recruiting some of their alveoli, and that's not inherently a bad thing. You're going to get some popping up in their good lung or in the good part of the bad lung. So you do want to try it, but you want to play it conservatively. But remember, you're going to get good airflow through these lungs anyway. It's a circulatory issue, so you're better off focusing on increasing the concentration of oxygen so that the parts of the lung that are getting perfused are picking up the maximal amount of oxygen that they can. So if you do get dispatched to something that is suspected to be a pulmonary embolism or cardiac arrest, that may end up being a pulmonary embolism based on the history, right? No cardiac history, no complaint of like gradually building chest pain, or Virchow's triad being prominent, easy to identify. I said scooping and running is reasonable in these patients, but you got to have a plan for where you're going. So there's TPA, which is the drug we use to bust clots in strokes. It's a very potent clot busting medication, and it's administered at stroke center. So you know that any stroke center, even if it's a small, like a primary stroke center, your small outlying hospitals that do offer primary care for strokes, they will have TPA. So you're better to scoop that patient up and go get them those fibrinolytics on board to start breaking that clot up. The data for giving the lytics prior to cardiac arrest is squishy at best, but there's reasonable data that show improved outcomes for patients once they go into cardiac arrest to receive these clot busting medications. Now, let's say you get somebody who looks like a P, smells like a P, you're pretty certain it's P, but they're conscious, they're breathing, they have not cardiac arrested yet. The definitive care for this could be fibrinolytics, it could be surgery depending on where the clot is. So you're going to want to take them somewhere specialized, that can do cardiothoracic surgery, that can do endovascular procedures, that has the good CT scanners, that has the specialist. So any level 1 trauma center is going to have every surgical subspecialty, and it's up to you guys to know the system that you're in. Does Methodist offer cardiothoracic surgery? Does Baptist have cardiothoracics and endovascular? So you got to know the system that you're working in to figure out where to take these patients so they get the care when they need it. Hyperventilation, we'll talk about panic attacks here in a second, but there can be physiologic hyperventilation. So our definition of hyperventilation is going to be breathing at a rate such that the arterial concentrations of CO2 dips out of the normal range. And so if you guys think back to the acid-base lecture, your body's compensation for a metabolic acidosis is a respiratory alkalosis, right? Your body has to balance. So I'm going to bring up our old friend here. Right? So this is the carbonic acid equilibrium equation. So if your body is undergoing a metabolic acidosis, we said that that's going to drop our bicarb, shoot our hydrogen up, right? And so when hydrogen goes up, the whole equation is going to shift this direction. Remember the rocking blue toy, right? When all the blue ends up on one side, what happens? You get a big wave that moves over to the other end, right? And things on opposite sides of the equation from each other go in proportion, and things on the same side go inverse, right? So hydrogen goes up, bicarb goes down because they're on the same side, and then the big wave moves to the other end and it makes more CO2. So your body, to get rid of that CO2, breathes faster to suck that back down. So you won't ever actually see the elevated CO2 because your body's going to be like, no, this is too much. And it will breathe faster and faster and faster. But as the hydrogen continues to accumulate, it's like, nope, we got to go. We can't, normal's not good enough, right? Because our pH is dropping because we've got too much hydrogen building up. So now we need less CO2 than normal. So bicarb down, hydrogen up, and your body needs to get rid of CO2 in order to keep the pH the same. Because if your body doesn't get rid of CO2, we know that CO2, as it rises, will push the equation back this direction, which is just going to cause the hydrogen to go up even more, right? So CO2 is your body's escape hatch out of this cycle. So when you start breathing faster, you dump CO2, you'll go below physiologic levels to compensate for a severe metabolic acidosis. So you're really, really septic patients, you're bad diabetic, ketoacidotic patients. There's a reason they're breathing 30, 40 times a minute. If they go unresponsive and you need to bag them, you need to continue bagging them at the rate they were breathing before they went down. If you've got end tidal, right, you want to measure their end tidal while they're still breathing, and that's your target when you bag them. Because if you don't maintain where they were, then that CO2 is going to start to creep up. Even if it goes back up to normal, that's going to not let the hydrogen get out of the body as quickly as it needs to, and your pH is going to tank down, and that's bad news. So a quickly breathing patient in the setting of any other disease state should be alarming and is typically indicative of a metabolic acidosis that's taking place. The big common one that you guys will see is sepsis. And then DKA is the other really clear-cut example where you get those Kussmaul respirations. So hyperventilation, not always a panic attack, can be physiologic, and you need to maintain that should you take over the patient's respirations. So now we're on to the panic attack side of things, right? So if there's no reason for your patient to need more oxygen, that higher respiratory rate, they're going to blow off CO2 unnecessarily, which will cause the pH to go up because that's a respiratory alkalosis. So as your pH rises, becomes more basic because you're dumping CO2 without the body putting additional hydrogen in from a metabolic process. That's where you're going to start getting these classic signs and symptoms of panic attack. So anxiety, dizziness, numbness, tingling in the hands and feet, and a sense of shortness of breath, which is sort of a malicious side effect, I think, because it causes them to panic even more and they breathe even faster and make everything worse. And the other one, sometimes you'll see this hands and feet will go beyond tingling and will actually start to spasm, call that carpal pedal spasm. So if you come up and somebody's hands, look like the guy from Scary Movie 2, I don't know if y'all are too young to get that reference, but the hand will be curled, rigid, flexed in towards the body. That means that their pH is rising and it causes a dysregulation in calcium, and causes muscle spasm. So if you see any of those symptoms setting in, it's pointing you towards a panic attack, but that doesn't necessarily mean that there's not also an underlying metabolic acidosis. It's your job to assume the worst and treat them for it, because you're better to treat them and be wrong than to miss something and have them decompensate and you not notice or not have any idea what happened. So this slide is really what we just talked about. The only addition here is that a clue that it could be a panic attack is that if it's in response to a recent psychological stress. But again, that doesn't preclude there being an underlying metabolic acidosis, right? They could be panicking because they know their blood sugar is getting high, or they feel terrible because their blood sugar is high, or they're altered from a UTI and they're going septic, and that's causing some anxiety. And you can usually have a pretty strong suspicion, but it needs to stay in the back of your mind that hyperventilation is not always just somebody panicking. So they deserve a full assessment, and you need to be wary of what else could be happening. So this is just saying that we can't figure it out outside the hospital. Get a good history, manage the bad stuff. And not a whole lot we can do for this other than be supportive, emotionally, psychologically to them. The old put the paper bag over the patient's mouth and nose, the theory behind that, and it's not a bad theory, right, is that when they breathe out, they're breathing out CO2, and it's less CO2 than they normally would because of their rate. But if they breathe it into a bag, then the CO2 will start to build up in the bag. So when they take a breath in, they're going to pull more and more CO2 back in with every breath. And that can help break the cycle, right? As you start putting excess CO2 into the body, you'll start to bring that pH back down, which can relieve some of those other symptoms. The problem is there ends up not being any oxygen in that bag and they desaturate, which is a problem in and of itself that we would like to avoid. So the old paper bag trick is no longer viable in modern EMS. Close your book, close your notes. I'm going to tell you a secret. Do not do this in lab. Do not do this on your test. But you can put a non-rebreather on somebody, right? And our normal non-rebreather is 10 to 15 liters per minute. If you put it on at 4 liters per minute, there is still oxygen coming through that mask, but it's not enough to meet their demand on every breath, right? So they will breathe some of their own air back in, but they will also be getting a little bit of oxygen with it. So that is a trick to stave off the hypoxia. It also makes them feel better, and typically will make people less anxious because they feel like you're treating them. They feel like they're getting oxygen. You can be like, here, I'm going to give you some oxygen. This is going to help you breathe. And they're usually very thankful and appreciative and, grab the mask, hold it to their face. which is great. And they start, because then they seal it, which means they are going to breathe in, more of their own CO2 as opposed to ambient air, and that can help them. That is super off-label. That is a trick of the trade. Again, if you can't keep real world and test world separate, forget I said anything. Do not put this in your notes. But that's the sort of real world practical solution if you've got somebody that you just can't get out of it and you are sure beyond any reasonable doubt that this is an anxiety attack and you want to try to do something about it. Airway obstruction, guys, this is basic. Foreign body, that's your BLS class. I don't need to tell you how to fix it. Most common airway obstruction, put a star next to this, is the tongue. That is on my test, it's on National Registry's test. I promise you will get some question that wants you to remember that the tongue is a huge problem in somebody who's unconscious or unresponsive, and that's why opening the airway is the first step in our patient care if it's not open when you get there. The only sort of clinical note I'm going to add to this is if you transport somebody with a partial obstruction, right, they might be stridorous, but they're still able to get some air past, go ahead and pre-oxygenate them so that if they do become completely occluded, they've got a nice reserve of oxygen, high concentration oxygen in their lungs that will last them significantly longer than if their lungs are just full of room air. So it is reasonable to go ahead and put some supplemental on regardless of what their oxygen saturation is and keep it on throughout transport. Be gentle, don't shake the light bulb, don't make them talk too much. Be careful moving them, don't make them move too much or turn their head. Have them just focus on holding the position that's easiest to breathe. Minimize the risk of dislodging whatever's blocking their airway partially and having it turn into a complete obstruction. Remember your abdominal thrust for adults, chest thrust if they're pregnant, back blows, and chest compressions for kids. I personally like nasal cannula for my supplemental oxygen because if you do have to suction them or a paramedic wants to go in and fish something out of the airway with the McGills, they can still be getting supplemental oxygen through the nose. It's not in the way. And if you've got those end-tidal nasal cannulas, if you're not eyes on your patient the entire time, which again, you should be, but I understand the realities of the job. You got to call a report. You got to, tell your partner to get the radio channel, whatever it might be. You're looking at the patient's med list. Hook your end-tidal up to your monitor. It'll let you know what their respiratory rate is. And a paramedic can look at the CO2 and make some judgments about how well they're ventilating and how well they're perfusing. And it just gives you a really early heads up. If you don't happen to have your eyes on the patient, if they have stopped breathing or declining. Environmental industrial exposure, the big take-home point here is if it's nasty, it's not your problem. Any test question about this is going to be looking for you to identify scene safety, right? The patient needs to be thoroughly decontaminated, remove them from the environment, fresh air. And we're going to get into all the toxicology stuff towards the end of this course. But you do need to know that shortness of breath, associated with cleaning, farming, or industrial activities, you want to look for cleaning solutions, acids or solvent type chemicals. Anything with chlorine is a profound respiratory irritant, and pesticides cause issues with mucus and the smooth muscle in your lungs as well. So make sure that those are on your differential, right? If you go to somebody's house and you smell the bleach in the air, obviously you need to get yourself out, but it needs to be high on your list of suspicions that that patient may have been exposed. and manage them accordingly. If it's a big industrial site, you're going to let hazmat or the on-site people deal with it. So once you do actually get your patient, guys, air in and out, blood around and around, right? If their breathing is ineffective, you ventilate them. If it's effective but distressed, you give them oxygen as needed and monitor for changes. CPAP will help with respiratory effort in most cases, and you need to be ready to manage their airway. Have your suction out, have your BLS adjuncts out, have your BVM out with your PEEP valve on. Know where your supraglottic airway device is and just have a plan for them getting worse. And then closely monitor for changes, fluids if they need blood pressure support. Cystic fibrosis is a really gnarly inherited genetic condition that causes what would normally be sort of thin, slippery secretions like mucus, sweat, digestive juices, end up being more like glue or tar, more of a sludge, and they block up all the organs where they're normally secreted, right? So your mucus is going to physically plug your lungs up, and the digestive fluid being thick and gloopy is going to clog up your GI tract. It's a really terrible disorder, poor life expectancy, but it's all supportive care, right? Patients are typically going to know that they have this. This isn't going to be news to them when you go get them. And this is one of those where you don't need to know what it is necessarily, right? But if you listen to them and you hear roncorous lung sounds, right? You hear phlegm and goop in their airways and they're hypoxic and they're struggling to breathe, what are you going to do? You're going to give them oxygen. You're going to try CPAP to improve that work of breathing and re-recruit some of those alveoli, and support their hemodynamics as necessary. If you want to play detective and figure it out, you can, ask about abdominal discomfort. Do they know if they have cystic fibrosis? Look at their medication list. There's a lot of very specific CF medications. If you want to look those up as part of your pharmacology project, that's cool. You can do that. But again, air in and out, blood around and around, how you go about doing that is not going to differ horribly much, as long as you know what bucket to put your treatments in, right? If they're wheezing, it's bronchospasm, they need albuterol. If there's increased respiratory effort and they're looking like they're fatiguing and you want to try CPAP, that's a really good way to go. If that makes things worse and it's a COPD exacerbation, you're not hearing the wheezing, then it's time for epinephrine. But things go into buckets. Doesn't matter what's causing the bronchospasm. Bronchospasm is bronchospasm. Plugged bronchial tree, whether it's from a pneumonia or a cystic fibrosis, or from an inhaled, foreign body that gets down into that tree, it doesn't matter. Your treatment is still the same, right? Deliver oxygen to the alveoli and make sure they don't tire out. And if they do, support them. Nothing changes. All right, real quick, we're going to blitz through some of these peds respiratory issues. Bronchiolitis is exactly what it sounds like. Itis is inflammation of the bronchioles, typically due to a viral infection, RSV being the big one. It looks like asthma, it sounds like asthma, but it's not asthma. So you'll hear wheezing. The difference is they will have a fever oftentimes with this, right? So if you get wheezing plus fever, or wheezing, with a history of a recent illness, that should raise your index of suspicion that it's bronchiolitis, right? And if a kid doesn't have an asthma diagnosis, that they're carrying, then it's probably not asthma. When you're seeing it's probably bronchiolitis. Albuterol, the mechanism behind the wheezing is not smooth muscle spasm. It's kids, their airway structure is a little bit different, just developmentally, than an adult. So the albuterol treatments are not particularly effective, if at all. But humidified oxygen is a champ here. And if they need help with their breathing, a BVM with a PEEP valve on it, and a nice seal will give you a little bit of a CPAP effect with the supplemental oxygen. These kids will typically do really well. RSV is the virus that most typically causes that, causes inflammation in the air passages, prevents, because their passages are so small, a little bit of inflammation goes a long way in blocking them completely off. So kids are particularly susceptible to getting severe respiratory complications from viruses, where adults might see more minor symptoms. Two major complications are either the bronchiolitis or a pneumonia, because the inflammation prevents them from getting germs, dust, contaminant from the outside world back up the respiratory tract to get coughed out. So that bacteria will sit, in the distal bronchial tree, set up shop, and turn into a pneumonia. RSV is super contagious. So if you do get a peds respiratory call and it's in the winter months, you should assume that they have RSV. Take some standard, you're going to want to wear a mask. If the kid will tolerate having, an oxygen mask over their face, you're going to want to do that. You don't want to bring it home to your kids or spread it to any of your other patients that you see throughout the day. Croup, I showed you the soundbite of croup back at the beginning of the lecture for airway infection. That's the inflammation of sort of your entire upper respiratory tree. It's not one specific agent. It's a virus that sets up shop in the upper respiratory and causes significant swelling in the region. So they will often sound stridorous and have that very distinctive seal bark cough. And they can spike a pretty relatively high fever when they've got this infection. The good news is these kids often look and sound worse than they actually are. A nice, calm, quiet environment with some humidified oxygen is pretty helpful. If that doesn't work, taking them out into the cold weather, since these usually happen in the winter months, the cold air it's like putting ice on an inflamed area. It will reduce the inflammation, makes their breathing a lot easier. So even having, standing outside in the cold for a few minutes before you get in the truck can help these patients. Medics can do some fancy stuff with steroids and epinephrine. But for you all, it's humidified oxygen, and I'm going to give you the little clinical pearl about the cold air. Stridor, seal bark, cough will let you know that that's what it is, and there's usually a buildup to it. Right, so kid came home from daycare, he's had a runny nose for a few days, it's going around, and guys, this always hits at 2 o'clock in the morning. It terrifies you as a parent. Your kid will wake up with that horrific sounding cough. They're crying, they're upset. It does get worse at night, so if you get called for it, it's probably going to be overnight. You need to be calm, and you need to keep the kid calm, because if they freak out and start crying and putting a bunch of air through there and they're stressed and they get their blood pressure up, you're going to make the swelling worse. So calm, humidified oxygen, cold air are your friends. All right, epiglottitis is exactly what it sounds like. Swelling of the epiglottis. Got a picture of that for you. talked about this in the airway lecture. We used to call this a disease of childhood, but ever since the Hib vaccine came out, we don't see it nearly as much in kids. It's becoming much more prominent in adults, and these people typically look terrible. Tripod position, drooling uncontrollably if they're a kid. If it's an adult, they'll have their head craned forward. And the reason for that is they have got to lift that epiglottis up off their tracheal opening. The normal mechanisms aren't working because it's so swollen. So they're having to position their own head to open their airway the same way we do with a head tilt, chin lift, or a jaw thrust. The swelling can onset very quickly. Typically presents with a high fever, sore throat. The very, very, very worst sore throat they've ever had is sort of the hallmark in adults. You may get some stridor, but you're going to hear a very muffled voice, right? Because the epiglottis sits, just above the vocal cords, and so that the sound coming out of the cords is hitting this very dense, swollen piece of tissue, so their voice will be muffled. Everything back there is all inflamed. And can be life-threatening is a little bit of an understatement, right? Because if they cannot get their epiglottis up off their tracheal opening, or their laryngeal opening, they will die. They can't breathe. Management for this is supplemental oxygen, keep them calm, and make sure the hospital knows that you're coming. Because they'll either need to get intubated, usually through the nose with a steerable fiber optic scope, or get a surgical airway through the neck. If you don't think you're going to make it to the hospital, or your patient, can no longer breathe at all, you're going to want a paramedic. Tennessee, they do the needle through the neck to breathe through. Where I was in New York, paramedics could actually scalpel through and stick a tube. But no matter where you are, paramedics are going to have the ability to secure an airway through the cricothyroid membrane. Pneumonia shouldn't be news to anybody. You get a bacterium that sets up in the lungs. A lot of things can predispose you to this. Inactivity, poor lung function at baseline, right? You're unable to clear stuff out of the lungs, or you're, young kid, underdeveloped immune system, immunosuppressed kids and adults. People who aren't able to get the bacterium out or fight them off once they're inside will develop these pockets of infection within the lungs themselves. Obviously, a lung that's full of bacteria and inflammation and pus, if they end up getting an abscess, not going to be able to use that lung for gas exchange, so they'll desaturate and require emergency medical attention. Typically presents with fever, although especially in the geriatric population, they don't always spike a fever. Productive cough means they're able to bring stuff up, and purulent means containing pus, so it'll be an opaque, greenish yellow typically, but an opaque sputum that comes up when they cough. Again, not a hard and fast finding, but it should raise your index of suspicion that you're dealing with a pneumonia. Chest pain is a plus minus. It's typically related to increased work of breathing that causes their chest to hurt, more so than the infection itself. And then this is what I told you is sort of the terminal issue for them, is the mucus causes your alveoli to clump up, stick together, get blocked off, sort of collapse in on themselves, making them ineffective for gas exchange. Whooping cough is highly, highly, highly contagious. It's an airborne bacterium. Good news is there's a vaccine for that. So as long as everybody stays on board with the science and continues to get that, you really hopefully won't ever see this during your career. If you do see it, you got to protect yourself. You're going to want an N95 for this because it is an airborne precaution. And then supportive care, keep them calm, blow by oxygen if they'll tolerate it, and bag them if they're too fatigued to breathe on their own or they stop. Airway obstruction, we don't need to discuss that too much. You guys should already know. Couple exam considerations for you though. Don't forget tonsillitis, especially in kids. A little bit of inflammation goes a long way in blocking that airway off. Trachs are prone to malposition or occlusion, and as an advanced EMT, you're expected to know how to troubleshoot that. That'll be a Mr. Camp thing over in the lab. And just because you can't see it in their mouth doesn't mean that there's not an obstruction, and even the paramedics with the laryngoscope might not see it, right? If it's a little bead or a raisin or something that can get down below the level of the cords, you can have a lower airway obstruction, and you just won't know until you get the x-ray or the CT scan back. So, and just because you can't see it, or they've got a good cough, doesn't mean that the airway is not occluded, particularly if they were eating or playing with small toys around the time that it happened. Again, all of these pediatric things are going to be supportive care. Oxygenate them, bag them if they need it, don't stress them out. Paramedic backup if things get dicey. Talked to you about croup already, humidified O2. You cannot do neb epi in the state of Tennessee, but it is worth noting that is sort of the magic bullet treatment for croup that can make the symptoms completely resolve within minutes, but it is very temporary, so it provides the patient some comfort, makes the transport much more pleasant, a lot less scary for everyone involved. But it's that dose of steroids that really will make the difference, and those are always outside your guys' scope. But if you work somewhere that'll let you nebulize epi and a patient sounds really bad or looks really distressed or the parents are really distressed, that nebulized epinephrine is a pretty magical treatment for this. And it's just because of the vasoconstriction. It clamps down all those blood vessels up top far more effectively than albuterol would. Albuterol is pretty selective for the lung tissue. Not quite as many vascular effects. Epinephrine will clamp those blood vessels down and nip the edema real fast. Epiglottitis, and do not agitate them. Do not try to look. Do not stick a tongue depressor, and do not let them stick anything in their mouth. Give them oxygen as tolerated, and just keep an eye on them. Let the parents keep them calm as you transport. That's the key to this, because there's nothing you can do about it but make it worse if you stress the kid out and make them freak out. So this over here, that's a normal epiglottis, right? This little flappy do right there. This is your epiglottis on epiglottitis. Look at that sucker. It's huge. Right, so you can see why intubating this patient would be a struggle, right? You can't even see the cords. That's your target right there, knowing full well that if you bump this guy, he's going to get bigger and take up even more space. So this is why epiglottitis is a life-threatening emergency. And you can see in the x-ray here, I'm going to outline the normal epiglottis is right there, and it's sort of this piece is the actual mobile flap right here, right? So when they swallow, it folds down to right here and blocks the trachea off, and your trachea lives right here. It's that track right there is your trachea. So the epiglottis flips down and covers it. Now, in somebody with epiglottitis, I'm going to outline that sucker again. It's so swollen that it can't pull up the way it's supposed to, right? So I'm going to erase this so you can see it. If this is their airway, right now the air has to go like that to get out, and you've got that little itty bitty space for all the air to get through, versus in this patient with the epiglottis fully open, you've got a nice wide, it looks narrow, but that can pull up that way. There's more room. You can see how much thicker this piece is, and it's laying completely horizontal across the airway because it's too swollen to get pulled back up into its normal position. Pneumonia, ABCs, fluid if they need it. Nothing new, nothing fancy there. So again, nothing new. Supportive care, don't shake the light bulb. If you get the older people with it, because their airway is so much wider than a kid, you don't usually get the whoop. You just get really, really severe, harsh, the kind of coughing that's just relentless, goes on, for a minute at a time, and lasts for weeks again. The good news about it is you can get that vaccine and never have to deal with it. Airway obstruction, listen for a change. Listen to the parents. When they tell you the kid doesn't sound right, something's wrong, you need to believe them and note that that kid could have something down deeper than the level of the cords, and you just have no way of knowing until you get an x-ray. I had a kid who managed to get a dime through his vocal cords, like putting a coin in an arcade machine. I don't know how he did it, but he had a dime sitting in his trachea. Had to go to surgery to get it out. Not a good time. Not a good time. CHF. We talked a little bit about it just because CPAP is going to be your go-to and nitroglycerin is in your scope if they're having chest pain. You cannot give it for congestive heart failure or pulmonary edema, but you can for chest pain. So if there's respiratory distress, ask them about the chest pain. And if it's there and they're crazy hypertensive, you can go ahead and hit them with that nitroglycerin using the chest pain protocol. I'm not telling you, look at me. I know you cannot look at me, but look at me. I am not telling you to give nitroglycerin for congestive heart failure. I'm telling you to give it for chest pain. If they happen to be having heart failure and trouble breathing as well, bully, you're going to kill two birds with one stone. But you can only give nitro for chest pain. I'm just saying they can go hand in hand, and you should take advantage of that fact. You're better to give oxygen and not need it than better to give it and not need it than need it and not give it. Your hypoxic drive is not going to kick in until well outside the EMS time frame, so go ahead and hit your COPDers with it, and if they're hypoxic anyway, then they need it. You don't have to worry about the hypoxic drive no matter how long they're on it. And reassess, and know what a successful treatment looks like, right? Like, what is our goal? You give albuterol, you want them to stop wheezing, right? You put CPAP on, you want decreased effort, decreased rate, increased comfort. What you don't want is hypotension. What you don't want is, gastric distension. So know what you're reassessing for with all of your interventions. And then this is just what to do with an altered mental or an unresponsive patient. And the answer, it's ensure a patent airway. So open it, suction it. If they need an adjunct, go for it. I like nasals first because our goal is to get them their gag reflex back. And I don't want to have a big thing in their mouth for them to gag on and vomit. If you're not getting good results with the nasal, by all means, go ahead and pop that oral airway in if they'll tolerate it. test taking pro tip here. Unresponsive patients. The advanced airway is never, ever, ever your primary maneuver. You're going to want to open, suction, place a basic adjunct, and immediately begin BVM ventilations. Your advanced airways take time, and when you first make contact, you don't want to delay initiating life-saving BLS care by administering BVM ventilations, screwing around trying to get an advanced airway in as soon as you show up. So it's BLS first, and then you can get fancy later. But if they remain unresponsive after you've BVM'd them and you've put a simple adjunct in and you want to get them loaded up for transport and not have to maintain a bag seal the whole way to the hospital, that's when your supraglottic airways will come out. Trach dysfunction, we'll talk a little bit more about this when we get to peds, but they can get blocked, they can bleed, from within, they can bleed from around, they can get pulled out, and they can get infected. None of that is going to change too much about what we do, right? You want to suction it to make sure it's patent. You want to suction blood out if it's there. The really big, scary trach bleed is a little bit beyond your scope to even tell you how to deal with it. So if you have major tracheostomy bleeding, you're going to want to get a paramedic, get med control on the phone. They can help you get fancy to fix it. But otherwise, guys, it's suction, supplemental oxygen, and that's it. Your BVM will hook up to a trach. So if your trach is good and it's just a trouble breathing, you can bag them through it. If there is a trach failure, you can bag them through the stoma with a pediatric mask, and you cover the nose and mouth while you breathe in, let it go during the exhale so the air can get back out. And nothing new, nothing fancy here. And it's not just kids that have these, especially as we get good at, or not good, as our ability to prolong the dying process improves and we keep people alive longer and longer and longer. You'll see these trachs in elderly patients as well. Typically, end-stage COPDers will get them, your bad congestive heart failure patients, and then a lot of cases, it's just to decrease the dead space, right? They have to cycle less air with every breath to get gas down into their alveoli. If you cut out the upper part of the trachea and the oronasopharynx, that's a lot of dead air that isn't being used for gas exchange. So you put the trach in, and it's sort of a straight shot right to the carina, and you cut out a lot of the extra air for them to move. You need to get a patent airway. So if the trach isn't working, you can bag through the nose and mouth if the trach is completely occluded. If the trach isn't completely occluded but isn't working, you put a mask over the entire site and you bag through that. Whether the whole thing needs to come out or not is a conversation for you to have with your paramedic and medical control. I'm not going to tell you empirically one way or another whether you need to do that. And that's all I'm going to say about that. Well, guys, we have made it to the end of the respiratory lecture. I'm looking forward to y'all's questions and the live session. Thanks for your patience. Thanks for sticking with me, and I will see you next time.